Once again, good afternoon, everybody. So this afternoon, we'll be talking about diabetes mellitus, always an interesting topic, and there's no end to the knowledge or the understanding of diabetes. My name, once again, is Dr. Awofisoye. With me here is...
I'm Olalekan. So okay. You're welcome.
So we'll be talking about the outpatient management of diabetes. Particularly, we'll try to emphasize the things that are maybe the areas that there's need for improvement for us healthcare practitioners generally, and a bit on the things that are relatively new knowledge, so to say.
Something that will aid our practice, and because we know we see these patients every day.
Absolutely.
And so what we need to do to make sure that we get the best out of what we're doing, both pharmacological and non-pharmacological measure. But before we delve into that, we'll still do a little bit of introduction to remind ourselves, as we know that the burden of cardiovascular disease is on the rise, and we know that hypertension and diabetes are the two major drivers of this cardiovascular disease and other complications associated with it in the country and in the developing nations generally. So, Dr. Awofisoye, let's introduce diabetes again to our people.
Absolutely. So we'll try to follow this outline. So I'm trying to get this moving. Okay, so we'll try to follow this outline: introduction, diagnosis, mainly focusing on treatment, obviously. And we all know what diabetes is. Diabetes is a chronic metabolic disorder in which we have hypoglycemia, which is due to deficiency in the way insulin works or the way insulin is produced, usually a combination of these two. And over a long time, it causes long-term damage, a lot of dysfunction in the body, and progressively causes the organs in the body to fail, especially the heart, the kidneys, the nerve, the blood vessels, and of course the heart as well. And beyond that, we know that if we achieve glycemic control and if we optimize cardiovascular risk in these patients, we can improve the long and short-term outcomes for these patients, which is our aim. Unfortunately, there's a lot of treatment gaps with diabetes. A lot of treatment goals are not being achieved, and I'm sure, like it is my own experience, a lot of us have that experience of us having people with diabetes come up with a lot of long-term complications. Over the past year, COVID has shown us that diabetes really does worsen outcomes.
Yes.
And I think out of all the patients I've seen with COVID, people with diabetes perhaps fared the worst.
Yes.
And so we need to address this, and the way we control glycemia, the way we optimize cardiovascular risk affects the long-term outcome in this patient.
Thank you very much. Like you said, and most of the mortality we've experienced from COVID, a lot of them had underlying diabetes that has not been properly managed. And that's one of the reasons why we felt we should talk about outpatient management of diabetes. So how do we classify diabetes?
Well, of course, there are a lot of suggestions recently about the classification of diabetes, but we will still go along with a very old classification that we use, the type 1 diabetes, in which there is predominantly deficiency in insulin secretion, and typically it's autoimmune. Sometimes you don't find these antibodies. And of course, the type that is called type 1A diabetes, type 1.5 diabetes, or so-called ladder, which is actually quite common, in which we have the autoimmune destruction of the beta cells, actually very slow, and usually, of course, occurs in people that are older, and usually they appear to respond to oral medications, but within a very short period of time, they start to require insulin. So that's the ladder. Of course, we have the type 2 diabetes, which...
Sorry, before you go on with type 2 diabetes,
yes,
you know, some people still talk about insulin dependent, non-insulin dependent. Is that different from this classification?
Well, that's the old classification, and it's still useful clinically, actually, because many times when you're managing someone with diabetes, you want to find out whether the person is requiring insulin or the person can be managed without insulin. Okay, but that's the old classification. And the reason why that classification was kind of revoked was because we now realize that actually any type of diabetes can require insulin, and you can require insulin at some point and not require insulin later along the line. So it's important that we classify that this current classification that we're using is actually based on the pathogenesis and the mechanisms that underlie diabetes itself. So we're saying that the type 2 diabetes forms the vast majority of people with diabetes, maybe up to 95% of diabetes. Even though, of course, a lot of people with LADA are actually misdiagnosed to have type 2 diabetes. Of course, gestational diabetes is rapidly increasing. It's outrageous, actually. I think earlier in the year, we had a talk about management of diabetes in pregnancy, which focused quite a bit on GDM. And of course, we now have other specific type of diabetes in which we have maybe up to 60 different types of diabetes under that group. The most prominent of which are the ones related to pancreatic disorders. We have the maturity onset diabetes of the young. And of course, we have other type of diabetes as well. We have steroid-induced or drug-induced. Recently, we've been having the transplantation-related diabetes mellitus. So the classification is like that. And it's actually important to know the type of diabetes we are dealing with ab initio when we are managing a patient, because it guides us in terms of the treatment and then prognosis, what to expect over the years.
So now looking based on this classification, how do we, the natural history of diabetes based on this classification, where do they come in, where do complications come in, and what are the underlying pathophysiology? You mentioned some, but can you also—
Absolutely. Like we said in the definition of diabetes, that the underlying pathophysiology of diabetes, of course, a lot of things to it, but a lot of it ends up leading to deficiency in insulin secretion and, of course, deficiency in insulin action. Funny enough, particularly for type 2 diabetes, this mechanism starts long before symptoms begin to manifest, and it only starts even years before diagnosis is made. And it's important to recognize this, because by the time you're seeing a patient with type 2 diabetes, many times you already have some micro and macrovascular complications that are established, okay? So deficiency in the amounts in the function of the beta cells and how much insulin they can produce starts. Okay, so we can start talking about with insulin resistance. So insulin resistance is there. Initially, it's compensated by the pancreas trying to produce excessive amounts of insulin to overcome this resistance. But over the years, the pancreas, the beta cells get dysfunctional, and they are unable to sustain the hyperinsulinemic state that overcomes insulin resistance. And then beta cell function begins to reduce, the incretin effect begins to reduce, and then postprandial glucose begins to rise. Then along the line, fasting glucose starts to rise. And of course, usually, of course, we typically have a pre-diabetic state, which can last a variable length of time before you start to have the overt type 2 diabetes. And then anywhere along the line is when the diagnosis is made. But even before the onset of what we can call diabetes itself, the pathogenesis is already ongoing. And that's why diabetes has a lot of multi-systemic involvement. And by the time we're seeing the patient, a lot of things have actually happened underlying it before.
So you are trying to say that by the time the patient is having symptoms, it means this thing has been occurring, especially in type 2 for
absolutely,
so many
absolutely.
years.
In fact, by the time you can detect hypoglycemia by laboratory tests, a lot of processes have been undergoing for years. And of course, you mentioned symptoms now, but remember that a lot of patients will not even have symptoms until the disease is well advanced. So that is and of course, as we continue to have less and less beta cell function and the glucose begin to rise and rise, you tend to have more and more and more complications over the years until we get to a certain stage. It's also important to learn from this graph that there's only so much you can help insulin resistance and impaired beta cell function. And after a while, actually, many patients will end up needing insulin, even with type 2 diabetes.
Okay, so that the issue of insulin dependent, non-insulin dependent is not as strict.
It is not as strict, even though from a treatment and a clinical point of view, well, we know that some patients need insulin as part of their treatment, some need insulin to survive, which will be type 1 diabetes, and then some can actually be treated with drugs. But yes, that's a whole classification, like you said. So going further, expanding this pathogenesis issue, of course, we've talked about the reduced pancreatic insulin secretion. Now, this is what we call the ominous octet. So we start from 1, which is what gives us the reduced insulin secretion in the pancreas, which is due to a pure beta cell dysfunction. That's part of the things underlying the pathogenesis of type 2 diabetes. And of course, we have increased in glucagon secretion. Now, we know that glucagon, cortisol, growth hormone are the counter-regulatory hormones and they oppose insulin action. So this is actually increased in type 2 diabetes, and it's one of the mechanisms that underlie the disease. The reason why it's important to talk about this so-called ominous uptake is that these are the things that we're actually exploiting now to expand the treatment of diabetes and to make it more robust, so to say. Now, of course, there's nothing really that addresses this increased glucagon secretion, even though the DPP-4 inhibitors and the GLP-1 agonists actually, they mitigate that to some extent. And of course, in the liver, we have increased gluconeogenesis, hepatic gluconeogenesis. We know that metformin counteracts this to some extent. Yes. And of course, we also know that we have increased lipolysis, which is actually exacerbated in things like diabetes ketoacidosis and very poorly controlled diabetes. And that's one of the mechanisms that underlie the weight loss that you have with diabetes. Now, we have the increased glucose reduction in the proximal tubules here, and that's the mechanism that the new drugs, the SGLT2 inhibitors are exploiting. Okay, we have the reduced glucose uptake in the skeletal muscles, especially postprandial, and that's part of what metformin addresses as well. Of course, we have the increasing effects which the DP4 analogs work through, and then we have some neurotransmission dysfunction in the brain, which underlies, part of what underlies obesity. It's so complex, and of course, we really don't have a
difficult, so it's still complex and difficult.
Absolutely, to be fine. Thank you very much.
So that means most of our medication has been designed to alter one or two of these steps.
Absolutely, okay. Absolutely, okay. Absolutely. So I think we'll talk about the diagnosis of diabetes now.
But before we do that, let's assess our knowledge of diabetes. So how do you make a diagnosis of diabetes mellitus? So we have a poll there. Please, we want every one of us to participate just to assess our knowledge. We have about two minutes to do this. So a 42-year-old man was just diagnosed with hypertension. A random blood sugar was done, and the result was 154 milligram per DL. That's 8.5 millimole. He has no symptoms, so which one is correct? So we're okay. Please, we want more people to participate. So the first option, the random blood glucose results exclude a diagnosis of diabetes mellitus. His next glucose check should be done in 1 to 2 years. You should order a fasting. Fasting glucose should be scheduled within a week. Then the last, HbA1c, which is glycated hemoglobin, has no role in diabetes diagnosis in this case. So let's give ourselves a minute more before.
Oh, like 30 seconds more.
Okay, about 30 seconds more for us to assess, discuss the diagnosis. Okay, thanks for participating.
Okay, thank you very much for participating.
So let's end the poll.
It's good that a lot of people chose the right answer. I'm very happy to see that. Okay, so we know that a normal random blood glucose is extremely weak in excluding a diagnosis of diabetes mellitus. In fact, if you get a random of even 101, you cannot exclude the diagnosis of diabetes mellitus. And if you have a good index of suspicion, you should actually try to do a proper fasting blood glucose. If you cannot, then an A1C might suffice. There's a patient I saw earlier this year. He actually did a random glucose of maybe he had a random of about 124 or so, just around the 120s earlier in the year. That's this 2021. And then later on this year, he came, of course, he was asked to do fasting at that time, but he didn't come back like many patients don't. And then he came later in the year with florid symptoms of diabetes mellitus. And indeed, his A1C was around 10. His fasting at that time was close to 160, okay? So a random has very little role in excluding diabetes mellitus. If it's high, it has a very, how do you say it? A very high negative, it has a very low negative predictive value, so it's negative predictive value.
So let's quickly talk about the diagnosis.
Absolutely. So diagnosis can be diagnosed under several circumstances. It can be in someone that is asymptomatic just on screening. So some people do health checks from time to time. Then it can be in people with certain symptoms. either symptoms of diabetes itself, particularly osmotic symptoms. And like the patients in the poll we just did, it can be in the context of other cardiovascular disease. So we do say that in people, for example, with hypertension or maybe obesity or cholesterol disturbances, if you find one, we should search for the other ones. Absolutely. So of course, in people that come with things that look like complications of diabetes, so I've seen a lot of patients until when they had some sort of vision impairments that they actually had to be checked for diabetes, and the diabetes was picked. Okay, so if you see things that can be caused by diabetes, visual problems, kidney issues, heart issues, stroke, it's also an opportunity to make a diagnosis of diabetes. Of course, for the patients that do well the most, are people that are picked on screening, asymptomatic, so you can start to control the sugar or the glucose before you tend to get symptoms or before you start to get complications. We are all familiar with this diagnostic criteria. Which one do you think is most commonly used amongst these diagnostic criteria?
I think it's the fasting blood sugar.
I think it's the fasting blood sugar. So the fasting is probably the most used to diagnose diabetes. But of course, more and more we use A1C as well, particularly when you're unable, when it's difficult or you're not sure that the patient is going to come back for a fasting, because particularly a patient that you're just having an encounter with the first time. So A1C is also important. And of course, in people who have borderline diabetic states, it's good to use an A1C to also clarify the borderline states, because we know that the A1C is more robust. Is more, what's the word? It stays longer. It's more durable, yes, than the fasting. So the fasting can easily be affected by your meals in the last 2 or 3 days, whereas the A1C tends to stay and tends to be repeatable and dependent. Okay, so that's that.
But before you leave, to me, first what you said about the fasting blood, there's a patient on the ward now that we are managing for hyperglycemic emergency. But when we ask her, it's like, no history of diabetes, but there's family history of diabetes. Yeah. Have you been checking your sugar? He said, yes, that she usually gets fasting around 8.
Wow.
I said, that is not normal. I said, no. So you will be shocked that most people don't. She's been checking because she has a family, but she doesn't know that fasting of 8
is totally abnormal. Totally abnormal. So, and I've seen a lot of clients like that as well, so that for some reasons they did the value and then it's actually diagnosis of diabetes, but they said the doctor told them that they don't have diabetes, but they need to start watching their sugar. We need to be clear-cut and frank with our patients. When a blood glucose level is diagnostic of diabetes, we should tell them so that they take it as serious as they should take it, because yes, diabetes can be asymptomatic in the early times, and that's when we actually want to catch it and then treat it aggressively before they start having complications. And as I said earlier, those people tend to do better. Now, of course, we have the pre-diabetic states, which we're going to talk about along the line. And of course, sometimes our glucose values and A1C can be a bit conflicting with each other, which we'll talk a bit of along the line as well. It's also important for you to understand the methodology used for the A1C where you practice, because there are different methodologies and all of them have their limitations, their flaws, and what they are resistant to, and the things that can cause them to have to make them unreliable, so to say. So that's part of the diagnosis. Now, going forward, I think I've shown this in the next slide. So it's important for us to know that diabetes hardly comes out of the blues. That's the truth. When people tell me, if I see someone with frank diabetes now, you told me that you had a normal fasting earlier in the year, of course, it can happen, but it's just not that common. That's the truth. Because remember the natural history slide that we did show earlier, the progression from the dysfunctions to pre-diabetes is a gradual process. It's a gradual process. Of course, I'm talking about type 2 diabetes now. We do know that type 1 diabetes can start fairly rapidly, actually, particularly because we do know that the autoimmune destruction of the beta cells can happen over a few weeks, actually. And by the time it gets lower than a certain threshold, you can start having the manifestations of diabetes. Okay, so but the road to diabetes is a long one, coming from normal to pre-diabetes to the overt diabetes. And of course, we want to actually pick it as early as possible so that we can try to advance. And of course, we know that the pre-diabetes is a state in which it can actually be reversed, at least technically. Okay. So going forward,
so the pre-diabetes.
Yeah, absolutely. So we know that the pre-diabetes is not really a separate entity. It's a transition zone along the spectrum of normal glycemia to dysglycemia.
Well, can the patients come back to normal?
Yes, the patient can come back to normal, but I tell them not to see it as so. Okay, but you can come back to normal. But when we tell patients that, we need to emphasize that it's normal now because of the things you're doing, because of the things you have changed. But if you stop because you now say that, oh, my fasting is now 80, and you stop what you're doing, in 3 months' time or in 3 weeks' time, it will rise up to where it was before, actually. So, but we still like to call it going to remission, or it's now normal, so to say. Okay. We should also know that the pre-diabetic state is a state that is actually with increased risk of type 2 diabetes mellitus in the future, obviously. But of course, cardiovascular risk factors is common among people with pre-diabetes, and cardiovascular disease is actually common as well. So people who have pre-diabetes are at higher risk for a stroke or a heart attack compared to people who are normal glycemic, so to say. And of course, we know that the association between the blood glucose and the A1C and the risk of subsequent diabetes is a continuous one. And so someone with a A1C of 6.3, which is in the borderline, compared to someone with a A1C of 6.0, someone with A1C of 6.3 has a higher risk. Yes. I think that's obvious, actually. Okay, so we do know, like you said, that among people who have borderline diabetes, over the next several years, about a third will revert back to normal glycemia, about a third will remain in the borderline zone, and about a third will progress to full-blown diabetes. And we know that the people who are likely to reverse back to normal are the people who make concrete changes. Like I tell my patients, people are able to lose weight, who made changes in their lifestyle, diet, exercise, and they're able to sustain them. Okay, those are the people that are more likely to be reversed. But of course, we know that it's a bit beyond that as well, because the strength of the genetics, family history, and all those other factors are contributory as well.
So before we continue, we want to remind us that this presentation is coming from a cardiovascular multispecialty hospital, and this is part of our CSR to help improve the knowledge
and practice
about cardiovascular diseases generally and practice of medicine. So going forward, what do we get in history or other things that we can consider that will also make us to get it right as far classifying patients into whether type 1,
absolutely. So I will tell you about a patient we admitted maybe about a month ago or so. So the guy came with a lean build. He was perhaps 35. He's been diagnosed with diabetes since maybe more than 5 years ago. And then he has been using the medications. He was on maximal doses of oral agents. And he told me that since diagnosis, he has never gotten a fasting of maybe less than 8 before. And that means that it's probably just not so responsive to the oral medication. So, and I told him, I had to tell him that the type of diabetes he has is not likely one that is responsive to oral medications. And indeed, we did this autoantibodies and GAD65. His high insulin and autoantibodies came out to be maybe times 1,000 the upper limit of normal, which shows that his type of diabetes is actually autoimmune. I've actually not seen him myself since discharge, but those kind of situations are common. So it's important for us to understand the type of diabetes that someone has, okay? Of course, there's nothing that is foolproof, unfortunately. A lot of the criteria has caveats, okay? But age and diagnosis, if we see diabetes at a younger age, particularly less than 30, we should ask ourselves whether it is indeed type 2 diabetes or type 1 diabetes. Of course, we know that type 2 diabetes is happening more and more at a younger age now, but when you see someone less than 30, we should ask around. Indeed, it's part of the criteria that can suggest ladder or maybe type 1 diabetes. So that's one. Secondly, of course, we know that type 2 diabetes has a strong genetic concordance. Family history is common in people with type 2 diabetes. Of course, that said, we know that in Nigeria, many times we don't have a family history, even globally anyway, but particularly was in Nigeria because many of us don't know what our grandparents died of. Yes. So, and of course, in type 1, family history is not so strong, whereas in other specific type of diabetes like the MODY, maturity onset diabetes or beyond, we have a strong family history that must have been present in at least 2 generations above the person. So in the parents and in the grandparents, usually there's a family history of diabetes, and there's a typical way in which MODY presents. So those things can guide us. And of course, when we see features of obesity or features of the metabolic syndrome, it can make us suspect that it's more likely to be type 2. Yeah, now, can type 1 diabetes in someone that is big? Yes, it can happen in anybody, but it's one of the things that make us think that it's likely type 2. On the contrary to that, if you see diabetes occurring in a lean person, particularly a very lean person, you should just ask yourself again, particularly if the person is not responding to oral agent. So again, the presence or absence of ketosis or ketoacidosis is also important. So in the typical type 1 diabetes, we know that they need insulin to survive, and because they need insulin to survive, they tend to go into ketoacidosis by the time they are not on any form of treatment. Okay, so that's in people that present with diabetes ketoacidosis, or people that have a tendency to go into DKA, we should suspect type 1 in them, even though we have the type of diabetes we call the flatbush diabetes. That's the type 2 diabetes, but that are just ketosis prone in this part of the world. Okay. Again, we should always assess the response to oral agents, and it's one of the key practical things that we do to actually determine or to guide us onto the type of diabetes that someone has. So of course, we'll talk about treatment intensification along the line, but in people who do not significantly respond to oral agents, it's unlikely that they do have type 2 diabetes, because of course we know that the oral agents are likely to work in type 2 diabetes. But some people, whether they use the drug or not, the glucose is just about the same. So it's probably not type 2 diabetes. And of course, we should also check the beta cell autoantibodies, including the GAD65 antibody, the insulin autoantibody, which you do here. And of course, also the other antibodies, zinc transporter antibodies, etc. So it's good to do them as a battery, and then it can, if they're present, they actually really suggest type 1 diabetes. We know that those antibodies are likely to wane along the course of the disease. So it's more likely to be detectable earlier in the course of the disease rather than later. We can also do fasting insulin and C-peptide levels for these patients. And of course, we know that in people with type 1 diabetes, the fasting insulin and C-peptide is likely to be very low. Yes. Okay. In type 2, it can be normal. And if you catch disease very early, it can actually be high. They can have hyperinsulinemia.
In the late part of type 2, when there is beta cell exhaustion.
Absolutely, it can also be low here, right?
So what do we do? We've seen different occasions where your fasting blood sugar is saying one thing and your glycated hemoglobin is saying another thing. So how do we resolve that conflict? Which one should we follow?
Actually, we see that a lot because we do A1C for most of our pre-diabetes patients and for all our diabetes patients. And we're actually trying to do some work on this currently. A lot of factors can underlie this, and I've listed some of it here. People who have high glycemic variability, in which if you check the glucose records of the person, you see a lot of lows, a lot of highs, and such people, you could catch many of the glucoses at the lows or the highs, and they may seem not to correspond with the A1C. That's one. And then secondly, many times you have recent change in the glycemic control. Recent change meaning that the glycemic control either recently got better or recently worse. We know that the A1C looks at the last 2 to 3 months, whereas particularly if it's just a spot glucose check you have, it just looks at now and then. So for example, let me use an example now. So let's say my fasting sugar has actually been bad over the last 3 months, okay? But I had something maybe 2 weeks ago, and I just changed a lot of things, and my sugar became better. That means my A1C, reflecting the last 3 months, is actually going to be high, whereas my fasting sugar can be better, can be low, exactly. Whereas the opposite can also happen. So let's say someone has been regular on his medications all along, the fasting glycemic control was just really good, or regular with his LB behaviors. But recently, in the last 2 weeks, some things happened. I could not use my drugs, or I went to where could I have gone to US for holidays, and I ate all the pizza and things, and then my sugar really went up. So you could get the A1C that looks not so bad, but the fasting is just off the roof. Okay, so those are possibilities. Of course, we have people that are on insulin treatment as well, for many reasons, but because of the short changes you can get in the glycemic control. So for example, someone could have been on a certain amount of treatment over the last 3 months, and the glucoses were very bad actually. But in the last 2 or 3 days, just started insulin treatment and the sugar normalized. So the glucose is looking very beautiful at the moment, but the A1C is looking horrible. Okay, so that can cause it. And of course, we have the hemoglobinopathies, iron deficiencies, anemias, basically things that affect the rate of turnover of the red cells. And those things that affect the turnover of the red cells, either increasing red cell turnover or reducing it, will also affect the A1C likewise. So those are the things you should think about when we see those discordants in the A1C and blood glucose levels. There's a client we have, I always talk about him. When he did his A1C with us, his A1C was maybe 8 point something on treatment for diabetes on 2 oral agents actually. Whereas when he did it in another hospital, it's in a government hospital actually, his A1C was around 4. In fact, they called him to repeat about 3 times, and the A1C remained very low like that. Okay, so for that kind of patient, it was later he now told me, when I saw him again, we're talking about it, when I realized that he now told me that his genotype is, I think, SC. Oh, okay, his genotype is SC. Now the assay we were doing was not fooled by that. The other assay was fooled by that. But as I said, each assay has its own strengths and weaknesses. So, so it's one of the things we should think about when people have those kind of discordants. And indeed, I routinely ask patients, we'll get those discordants for their genotype. So of course, the red cell turnover, those kind of things can also be affected by blood transfusion. So obviously, someone got transfused with blood. The A1C, if the blood is donated by a diabetic person, the A1C can be higher. Yes. And of course, if the blood was given, can also dilute. Sorry, if the blood was from a non-diabetic, a normal glycemic person, it can dilute. So that can also fool us as well. So we should just put those things in mind when we're doing this.
But in practice,
yes,
which one do we follow?
I think most of the time we should actually explore what is likely underlying it. Okay. And when we understand that, it can guide us. But usually I tell people to err on the side of the A1C. Yes, A1C has a lot of limitations, especially in Africans, and many of these limitations has not been researched enough, so to say. Okay, but at the end of the day, at least from my experience, the A1C is usually the more durable one, especially if you're using a reliable assay. It's important to say that. And of course, it's probably not all the A1C, particularly the point of care equipment has been certified by the certifying agencies.
Okay, thank you very much. So let me remind us that we can put our question in the
chat box,
in the Q&A and the chat box, and we'll take them at the end of the presentation. We've talked about diagnosis, classification. Now we go full-blown into the management, and we should not forget our focus this evening is the outpatient management. We're not going to talk about DKA, HHS, but how you manage patients in the clinic to prevent them from even getting to those areas. So we'll be going into the management. And so what are the management principles?
Okay, so very briefly, the principle of managing diabetes, particularly in outpatients, is that number one, we want to screen patients as risk of diabetes. And I think we've talked a lot about the patient as risk over the years. Everybody, once you get to across a certain age, you should be screened. By the time you're getting above 35, by the time you get into your 40s, especially if you had an abnormal screening in the past, you have a family member with diabetes, or you have any other cardiovascular risk factor. So screening patients is key. So if you have someone with hypertension, for example, in your clinic, and the person has not had a recent fasting blood glucose, like in the last 1 or 2 years, you're actually putting the person at risk. So we should check. That's one. Secondly, of course, when we diagnose patients with diabetes, we need to educate them. One of my teachers, Prof, used to say that if you are to give someone with diabetes, either treatment or education, you should educate them. Because once you educate them, they're not likely to get it wrong at all. Because even if they have a bad doctor, they will be able to tell that, no, I'm not getting the right care here, and then they can move themselves away from that. Okay, so education, of course, we emphasize lifestyle changes as well. It's critical to do lifestyle changes in anyone. Now, many patients make it sound as though it's either lifestyle change or medication. No. Lifestyle changes is for everybody, regardless of whether the person needs medication or not. And it's important for me to say that we need to treat to target. I think there's somewhere where we physicians are perhaps not doing enough. A lot of people are on treatment, like the person I mentioned that had a hit, that his fasting he has never gotten the fasting less than 8 before, and he has been on medications. So what are we using the medications for? So the treatment is not just to control symptoms, at least that's not even that's not part of it at all.
I believe we will talk about the target as well.
Absolutely, yes, we'll talk about the target. So yes, so we should treat to target is important. Of course, while trying to live life as normal and as beautiful as possible. And of course, we want to identify complications early, we want to treat them, we want to monitor the complications. And we do this thing in a patient-centered fashion. using evidence-based treatment that's individualized, and I want to do it in the context of a multidisciplinary team. Okay, so you are a doctor or you're a nurse, and you're the only one that's managing the patient. No. You need a dietitian, you need a diabetes educator, you need a physical therapist in some situations. So it has to be a holistic care, and that's where the patient is likely going to get the best out of us. So talking about the diabetes education now, is to actually be, it should be linked to diabetes support system. So many places there are many ways you can support diabetes patients, either in internet resources where they can get certain information, WhatsApp group, or a number they can call to get certain information. Just there's a need for a support system because it's actually easy to feel lonely as a diabetes patient. That's the truth. Especially if you don't have any close friend that has the kind of condition you have. I've seen it over the years that patients who have a family member who has diabetes or had diabetes, they're more likely to be able to deal with it better because they get some support here. Exactly.
So that's I saw a patient yesterday that came, and when she came, she was telling me that she's feeling very bad. That when she came, she's a young person, that she looked around, everybody around there were older, and so she felt bad. What have I done to myself? What am I doing here? So I think that support is very, very important.
It's very important actually, and I think we need to work more on that actually. So what we want to do is to actually give the knowledge, skills, and the full ability for the patient to care for him or herself. Again, so that even when their healthcare assessing issues, so the person is not able to go to the hospitals or on strike, blah, 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 they can still do some things to ensure that the care is continued. And we remember that the diabetes parent is on their own more than 90% of the time. So it's actually a self-managed disease, of course, under the guidance and the support of the healthcare system. Of course, we want to give them that support. I've talked about that. And then there's critical times in which we should offer this kind of education and support. At the time of diagnosis, at least annually, patients should have a very comprehensive session, and that should include all the.
So it's not a one-time thing. That I've done it at the diagnosis. I don't need to talk again.
Absolutely. That education has to be continuous. And when complications arise, when there are issues, and of course when there are transitions in care, so they left one hospital and they joined their own hospital, they move from one town to the other, and then something changed. You need to really reassess where the educational level is at relating to diabetes, and of course update it, correct some things, encourage them, okay? And our goals is to get good clinical outcomes. We should give them a good quality of life, and we should keep assessing this from time to time. Again, this kind of education has to be patient-centered. It has to be centered around the patient, and it can be done in with individual patients or in groups. Both are actually necessary. So just counseling the patient one-on-one, there's some other advantage you can get in counseling in group, because some people learn from other people's problems, so to say, and we should leverage on the IT, creating webinars, WhatsApp group, and things like that for people who are interested. And we'll be surprised at how much patients actually have interest. Absolutely.
So I've heard people saying, once you have diabetes, you should not eat carbohydrates. You should not eat this. Just be eating beans. So what is your response to that?
Well, unfortunately, I think we're the ones that must have sold this into patients over the years. And it's one of those things that once you push out, then it's difficult to change the people's perception about that. So basically, a lot of people have labeled carbohydrates as a bad guy now. Okay, so as much as possible, we want people to be able to live a normal, healthy, and enjoyable life. We want people to still enjoy the pleasure of eating, actually, despite having diabetes. And of course, we know that beans is actually a predominantly carbohydrates meal, even though it's rich in protein. Okay, but what we preach is actually a diet that is low in carbohydrates. Of course, some people try to do the low calorie diets, very low carbohydrate diets, which is controversial. Okay, but we want portion control be part of the key things that we preach. Now, a lot of patients ask for dietary sheets. What should I not eat? In fact, that's one of the things they ask me for. Doctor, what should I not eat? It's not like that. Of course, we don't want. There's nobody that should be eating highly refined sugar, the ice cream, cake, and all. It's not good for anybody. It's not good for people with diabetes. It's not good for anybody without diabetes either. Okay, but portion control of a healthy meal is important. Calorie restriction. Know how much you're eating per time. Know how to reduce it. We should go for meals that have higher fiber. Either going for whole grains, making vegetable part and parcel of our meals. And we remind patients that a balanced diet is a diet that controls all the classes of food in the right proportion. Okay, so if you eat a meal that does not have vegetables, it's actually not a balanced diet, no matter how rich or how expensive that place might have been. Okay, of course, apart from the diet, which is key and critical, a lot of patients also try to talk about the timing of their meals, which is fine. We discourage people from eating late in the night. It's not good. Okay, but the total amount of carbs you take in the 24-hour period is actually the most important part. Of course, it's good to space the meals. It's good for the meals not to be too large per time. Of course, physical activity is very important, and a lot of patients actually struggle with this. They struggle with sustaining it, especially young, busy professionals. I can understand that it can be difficult to create time to exercise. And in this age and time, many people have a lot of reasons not to be able to exercise enough. Unfortunately, physical activity, adequate physical activity is key in the management of diabetes for obvious reasons. Increased skeletal muscle, glucose uptake, and all of those things. And patients actually notice that the week they did more exercise, the sugars tend to be better. Okay, and that's part of why we encourage people to check their sugar so that they get that feedback and it encourages them to do the right thing for time. It's important to individualize these changes, and what works for the one person may not work for another. A lot of people try the so-called keto diet, which I'm not really a fan of, but I've seen it work for some people, and if it works for you, no problem, okay? Some people, instead of doing the exercise on 30 minutes a day, they try to do what is very intense for them on Saturday and Sunday alone because their weeks are busy. As much as that may not be the best approach, if you that's what works for that person. And then I look for ways to actually augment and increase what they do during the week. Okay, it's important that when people start exercise, they start gradually and they intensify it as fitness is developed. There's a guy I saw, I think I've talked about it in one of the webinars before, that he had a heart attack while running. I think it was diagnosed with diabetes, and then he did not want to use drugs for some reason. So I don't think he stopped using the drugs, and he was exercising intensely. And then one day he was running, and then he had a severe crushing chest pain, and then he had to stop. And then he had heart failure symptoms over the next several weeks. I think I saw him about a month down the line. Unfortunately, for some reasons, you couldn't get coronary angiography and things done, and I'm not saying for a long time actually. But it's important to start exercise gradually and intensify it as fitness is developed. And for our patients that are at higher risk, we should actually encourage them to do at least basic screening before they do more intense physical exercise.
Thank you very much. So now we have classified, we've made the diagnosis, and we've started the lifestyle changes, which is key parts of the management. Now we want to initiate drugs or other things.
Absolutely.
How do we do that? But before that, let's test our knowledge.
Absolutely.
What we've been doing at our various end. So we want to take this second poll.
Okay, so let's run the second poll and see. There you go. So
how do you initiate treatment for patients with diabetes mellitus? So we have here Aisha, 51-year-old secretary, presenting with fatigue, excessive urination of 2 weeks duration. Her BMI was 38. The blood pressure 118/72 millimeter mercury. When she came to clinic, her MP was positive. There was glucose in urinalysis, and fasting blood glucose was 160. So glycated hemoglobin 8.8%. So make your choice, a single choice. A is unlikely to be type 2 diabetes. B, no glycemic treatment should be started now, but the blood glucose should be repeated. C, the patient should be commenced on metformin 500 mg BD. The patient should be started on metformin 1 gram BD, or you do lifestyle modification alone for the treatment in these patients. So let's pick our choice. We have a minute more to go.
Participate.
We just want to know what we've been doing so that by the time we go into the treatment initiation, what to do, how to do it, we'll get to learn more and better.
I think at some point we'll take some of the questions, so we don't wait until
the end. So that we go to the end.
On the slide 30.
So 10 seconds more.
Okay, thank you for participating.
Let's end the poll.
90 people participated. So I'm going to end the poll now. Okay, so again, I'm happy that most of the people chose the right answer. So obviously, this is type 2 diabetes. The fasting meets the criteria. The A1C meets the criteria. And when a patient who has symptoms like this, it's really inappropriate not to start any treatment at this time. Actually, the patient needs some form of treatment, and lifestyle modification alone will not be appropriate for someone that has symptoms like this. Fasting of 160, A1C of 8.8. So the patient needs to be.
You repeat if the patient is
asymptomatic, exactly. But in this patient is symptomatic. In fact, you can tell the patient to repeat on another day, and you may not see that patient again. Okay, so patient should be started on treatment. I think metformin 500 mg BD will be appropriate there. One can also use. You can actually justify using double agents, but I think I will be cautious. If you go by the ACE guideline, it actually suggests that you should consider dual therapy at this A1C. But in this case, I think 500 milligrams BD will probably actually be enough.
You can review and
exactly. It's important to start metformin small before increasing the dose because it improves the tolerance and the compliance. So starting 1000 milligrams BD for metformin straight away is not usually recommended. So thank you for participating in that poll. But now we'll actually just explore on the management of diabetes now. So a lot of things should be considered when we initiate treatment, and I think these are the kind of things we consider. There are probably a few more things, okay, but whether there are symptoms or not is important. It's not alone in itself, okay, but when there are symptoms, obviously the person usually needs to be treated, and you probably need to be a little bit aggressive, okay? Otherwise, the patient can progress to having either diabetes ketoacidosis or the HHS. Of course, when there are concurrent acute illnesses, it's important to start treatment as well. And important to start treatments a little bit hard or firmly. Of course, patient characteristics and preferences. So some patients are more likely to be able to do lifestyle modification. Some patients are motivated. So those things you actually consider when we are starting patients on medications or not, okay? And also the degree of hypoglycemia is important. So you should consider the degree of the fasting, postprandial, random glucose, and A1C. So for example, in someone that has diabetes with a fasting of 128, of course, you should start treatment with lifestyle. You may not necessarily need to start medication at that time, or A1C of 6.7. So yes, that is diabetes, but whether or not you need medications and what kind of medication you use depends on many other things, which we are going to talk about. Of course, presence of chronic complications is important. When there are chronic complications already, I think you should start treatment straight away so you don't get more problems. And of course, cardiovascular risk. If people have more cardiovascular risk, you probably want to start treating. You have a lower threshold to treat because we know that cardiovascular risk are additive and the overall will increase the risk of the patient. And also, you put the comorbidities into context when you're choosing the kind of treatment to give the patient. Of course, you also consider frailty and life expectancy. In some patients who are very frail or with a short life expectancy, you may not necessarily do anything sometimes. So you have an 80-year-old person that has an advanced cancer, and then at that 80-year-old, until the person start taking, I don't know, bread or whatever person likes taking. Oh no, probably we should take it easy with the person.
And maybe your target too
will be very relaxed for such a person. So if someone that is already, I don't know, 88, that is frail and hardly unable to move from the bed and has a fasting of 127, you may not necessarily need to push the treatment. If you want to push, you might just treat to something very mild.
So let's be more specific now.
Absolutely.
How do you do these drugs?
Absolutely. So in talking about how we choose the medications, of course, over the years, metformin remains the first line and is still the first line. But as we highlighted during that poll question, we should start slow and go slow. So we start at a small dose, 50 milligrams daily or twice a day, and we gradually increase the dose over the weeks. There's no hurry with metformin. It's not a fast medication. It's not a fast-acting medication. So there's no hurry whatsoever to use 1000 milligrams BD straight away. If we do need something intense earlier, then it's better you combine your metformin with a second agent, which of course we have quite a number of second-line agents you can use. You can use any of the sulfonylureas, a DP4 inhibitors, or one of the SGLT2 inhibitors. Sorry about that typographical error there. Okay, and when we're choosing a second agent, we think about the treatment gap we have. So the amount of gap between your targets and what the sugar is currently in, you may need something that is more potent.
Okay.
We need something that is more potent. I'm not sure what, so we need something that is more potent. So amongst these medications, we know that the sulfonylureas and the SGLT2 are perhaps the most potent. The DP4 are milder agents. Of course, there are a lot of milder agents as well. I'm sure we
will have to consider other things like the costs.
Absolutely.
Because there's no point writing
a medication
SGLT for a patient that cannot afford it when maybe glyburide with metformin would have done.
Absolutely. Absolutely. And we have a lot of patients that will not actually tell you when they cannot afford the medication. They will just get it and they use it for 2 weeks and they stop all treatment. They may not show up again. And then you now see them a year later with complication and they tell you that drug you prescribed, I cannot afford it. So I was just managing myself. I said I should just be doing diet alone. So it's important for us to have those honest conversations with our patients actually.
And I've also heard about some drugs as affecting body weight, or some drugs being better in maybe obese patients, in lean patients. Which one?
The sulfonylureas are actually, they promote weight gain. The insulin also promote weight gain to some extent, whereas DP4s are likely weight neutral or can cause maybe encourage a little bit of weight loss. Metformin 2 can promote a slight weight loss. The SGLT2 and the GLP-1 agonists actually promote some weight loss. So in people that are obese, they are the preferred agent if the patient is able to bear with the cost and other things that are shared with those drugs.
But are these drugs, are they available around?
Yes, they're available, thankfully. The SGLT2 inhibitors are available now around. We have empagliflozin, which we've started using quite a bit in our practice. DP4 inhibitors have been around for a long time, and the sulfonylureas, of course, have been around for decades in Nigeria. The GLP-1 agonists are around, they're available. Of course, they're a bit pricey, but they're available, and I have quite a bit of patients on them as well.
Okay, so now, initial therapy, how does glycated hemoglobin, fasting blood sugar affect your choice?
Absolutely.
How you start?
Absolutely. So sometimes you can actually genuinely do just lifestyle changes alone without needing medications. Especially so if your A1C is less than 7.5%, you can do lifestyle modifications alone in a motivated patient. But if the patient is not motivated, or if there are any queries, you can start your metformin at a certain dose alongside the lifestyle modification. And then if the lifestyle modification is if the A1C is not in targets, in 3 months' time, we can escalate the treatment as necessary. And just as the ACE guideline recommends, once the A1C is greater than 7.5%, you should actually consider adding a second agent at the outset. But the least, you need to start medications at that time. So you need to start metformin alongside healthy behaviors. For most patients, you should consider whether you should add a second agent or not. And depends on how high the glycemia is. Again, you can either consider adding a DP4 inhibitor as a second agent ab initio, or a sulfonylurea ab initio. And of course, these days, the people who have established cardiovascular disease, or heart failure, or who are at a higher risk of cardiovascular issues, and even for the regular patient, actually, you can consider an SGLT2 inhibitor as your second agent.
When do you bring in your insulin along this?
Absolutely, absolutely. So yeah, I will bring in the insulin in people in which that start at initial therapy, yes. People that are symptomatic, one, or have a severe hypoglycemia. So by the time you're getting A1C of 10, even though of course the ACE guideline uses a lower threshold, I think they use 9. We'll get to it in the next slide. So, but in people who are symptomatic, who are acutely ill, or who have very severe extent of dysglycemia, usually A1C above 9, you should consider starting insulin. Additionally, out of the onset, of course, if there are queries about the type of diabetes the patient has, we should consider that as well. So, this is the ACE algorithm, and usually we want the A1C to be less than 6.5. So we want it to be less than 6.5, that's the target, generally speaking.
Please, before you go on.
Yes, please.
You said the target should be less than 6.5. So where I don't have like A1C,
yes.
What can I use my fasting?
Yes, we can use the fasting. And in the one algorithm, which I'll show after, we try to put some fasting number of values that you can use. But in this age and time, I want to believe that most people are treating diabetes with A1Cs actually, because a lot of things can affect the fasting acutely. That may make it.
This is Nigeria.
Well, okay. So what targets fasting? We want the target fasting to be between 80 and 120, earlier preferably less than 110, even though I know that the recent ADA guidelines have accepted up to 130 for target fasting, but I think that is that will not do too much justice for the person. So 80 and 120 fasting, less than 110 preferably, particularly if it's easy to achieve that. Okay. So, but let's go with this guide, quickly go through this guideline. So lifestyle and ongoing glucose monitoring for everybody. They say they prefer CGM here, which we'll talk about CGM along the line. Independent of glycemic control in people that are high risk, even if they are not, even if glycemic control is good, you want to see if you can chip in an SGLT2 inhibitor. Okay, I won't talk so much about the GLP-1 agonists, but just know that there's a good role for SGLT2 inhibitors, and hopefully that role is actually picking up and more, even on our practice here. So if the A1C is less than 7.5, usually you can do a monotherapy with metformin, preferably. In people that are not tolerating metformin because of GI side effects, we see the GI side effects a bit, right? Diarrhea, constipation, rumbling, that they cannot take it. So you can consider other agents. Yeah, it will be a sulfonylurea or a DPP-4 inhibitors, but know that you can also use the GLP-1, which is an injectable, or SGLT2 inhibitors. I have quite a few patients do that because they cannot tolerate metformin, they have to be on insulin. And in people that actually have severe symptoms from that, they actually prefer the insulin than for someone to try them on metformin again. So it's important to know that. And when your A1C is greater than 7.5, you should consider dual therapy or even triple therapy, which requires a bit air. Triple therapy is tricky. The marginal A1C reduction you get is slim, perhaps less than 1 or 1.5%. Okay, but it's something that we still do for a lot of patients. And I think as at 3 or 4 years ago, it was not common practice in Nigeria, but I think it's more and more common here now. Okay, when people in which the A1C is greater than 9, especially if they have symptoms, and then you should consider using insulin from the outset. In people who have an A1C of greater than 9, it's inappropriate to just place on a single agent at that time. You're just going to waste a lot of time achieving very little. Okay.
About insulin, I've seen so many patients, even very literate patients. Yeah. That says no, never. You cannot give me insulin. And I used to educate that even giving you insulin help to preserve the beta islet cell and then help your pancreas. But it's like there's this taboo. It's like God, they will not use a knife to bring baby out of me. So how do we correct this?
I think
among doctors,
you're right. The truth is that it has been, I think the way it was introduced into diabetes care in Nigeria, maybe in many countries as well, as if it's a sign of failure, so to say. And sadly, we still use the term beta cell failure sometimes. So as if the patient has not succeeded in managing his diabetes with tablets and with lifestyle, and then therefore they have to use insulin. But hopefully, I think the paradigm is changing bit by bit. It's changing bit by bit, and we need to keep educating ourselves and of people that, first of all, diabetes, we say lifestyle disease sometimes. Diabetes is actually a disease. There's some failure in the processes going on in the body. The failure may be amenable to drug treatment or may not be. Many times you might need to give insulin, which is the agent that is missing or deficient. You may need to give it externally. Hopefully the paradigm will continue to change. So this is the algorithm that we may. So basically in people who have no symptoms, and then the fasting is less than 140, A1C less than 7. If the patient is motivated, you can consider lifestyle treatment only. But if you do that, you have to make sure the patient is monitoring, reassess in 3 months with both your A1C and the glucose monitoring. If it's working, fine. If it's not working, then of course you need to escalate to starting treatment. So this second column here now, people who are fasting of greater than 140, between 140 and 160, and then the A1C is between 7 and 8, consider monotherapy for the patient, and metformin is a preferred agent. If the targets continue to be met, we continue treatment. Now, people that are coming in with some symptoms without any acute illness, so to say, and the A1C between 8 and 9, fasting greater than 160, you should actually consider dual therapy for the patients. And the dual therapy will be metformin plus either of the second line agents, either sulfonylurea, DPP-4 inhibitors or SGLT2 inhibitors. And of course, if the target is not met in 3 months, you either consider a triple therapy, or preferably a specialist referral for inputs. Now, if targets are not met in 3 months, it's either as if someone is on triple therapy, if target is not met in 3 months, you need to consider adding insulin to the treatment. Now, of course, this process, we say 3 months, but many times this process it could be shorter, but many times it actually takes years that the patient is on, and that's not ideal. We don't want patients to have exposure to hyperglycemia for too long because the outcomes are worse.
So that means if we follow up the patient very well,
absolutely,
it's not compulsory for you to wait till 3 months
to
make
the decisions on that this is not working. Okay, and now in patients who have severe symptoms, A1C greater than 9 or you have a fasting of greater than 160, we need to consider specialist referral early, and then insulin plus or minus other agents early as well. So I think it's important to use this. Now, between fasting and A1C, the more reliable and the more robust is the A1C, obviously. And the fasting we use in this line is actually the hybrid fasting. So it's better if you've done it more than one time and then you put the hybrid together to give you a more solid statement.
Thank you very much. So again, we're coming to you from Cardiocare multispecialty hospital, where we manage the cardiovascular diseases, hypertension, heart failure, diabetes, with all the specialists doing 24 hours coverage. So if you need a specialist inputs, so kindly send your patients, you can do glycated hemoglobin, do the C-peptide,
fasting insulin,
assay for all the antibodies so that we can help your patient, and you are sure that you get a feedback from us about anybody that you send to us. So when we're starting, we're talking about patient-centered, involving the patients. So how do we bring the patient into monitoring of their blood sugar? Because we talked a lot about the blood sugar results. So how do we bring the patient, or do we just need to wait till come 1 month, come and check your blood sugar and leave the patient like
absolutely that? I think particularly because of the ease of which glucometers can be obtained these days, it's important for the patients to monitor, not just for treatment decisions, but to involve the patient in their treatment, like you said. So it's important for patients to be monitoring their sugars at home and to be able to understand the relationship between their meals, their medications, physical activity, and the sugar itself, and they can understand it, so that by the time they get this kind of so reading, they know that it's because of this, it's because of that. Those patients are far more likely to make and sustain health-changing behaviors at home. Okay, so now how frequently should a patient check their sugars? So that's a tricky one. I know a lot of patients that check their sugars every blessed day, and what treatment are they on? They are made for me, or maybe they're just on lifestyle changes. It's probably excessive, and a lot of patients do just fasting. They don't check at other times of the day. Whereas it's good to have a 360-degree view of the sugars. Know what it reads after meal, what it typically reads before meal, what it reads at bedtime. So
then maybe after a particular type of meal, you can assess.
Absolutely. So I tell patients that a lot, that when they eat certain meals and they're not sure of the impact. So someone introduced you to a particular meal and I say that it's good, that it doesn't raise blood sugar so much.
Because at the time it was wheat that was ready.
Yeah, exactly.
Just be eating wheat, and later people start coming with different type of
things. Absolutely. So it's good for them to check like that, and then they see that, oh, when I ate this so-called potato porridge that someone introduced me to, my sugar actually went up. Then I stopped, I went back to my unripe plantain porridge, those kind of things. So they just learn from that and they're able to make their decisions on it. So of course, patients that are motivated enough, we should encourage them. Patients that have severe hypoglycemia, that is, their sugar is uncontrolled, they should check more frequently actually. People that are on more intensive treatment, people that are on triple regimen, was everybody on insulin, and people that are at high risk of hypoglycemia, they need to check more often so that they can. So imagine someone that's had hypoglycemia twice before and they're still on a sulfonylurea or other agents that are prone to give them, they need to check because they don't know when they're getting to 3 point something and they're almost, so they need to check more frequently. And of course, the patient should be familiar with their A1C. When a patient is referred to me and I want to know how well the patient has understood that this is my name. But one of the things I asked, like, what's your last A1C?
Doctors, we don't like to share those information with patients. We believe if you tell patient, maybe the patient will go to another clinic.
Well, yeah, we should not think like that. Actually, we should not think like that. We should involve patients more and more in their care, so that at least if I ask a patient that what's your last A1C, and patient is able to tell me, they know how well they're doing, they know how well they're not doing. And then even before you suggest to them that they need to be switched to insulin, they start to say to themselves that, doctor, are you sure that this is my A1C? I'm using all these drugs you prescribed for me, and yet my A1C is still 8.8%. Doctor, it's not working. They can tell, they can, and then they are motivated to, okay? And of course, it encourages us also to intensify when the treatments are not at goal.
You said something that struck me. The risk of hypoglycemia. That means you need to educate these patients and tell them,
absolutely,
why you're taking this can happen, and you can have this. Because some patients, we've seen patients just taking medication, continue to take medication until they were brought in almost unconscious.
You're right. I think doctors often don't do this enough. We don't do this enough, and we tend to do it better when we're starting patients on insulin, but it doesn't have to be so. The risk of hypoglycemia with sulfonylureas is actually quite significant, actually. And a lot of the hypoglycemia we see is actually in patients that are on sulfonylureas. Sulfonylureas are extensively used in the management of diabetes in Nigeria. So we need to teach patients about hypoglycemia. People that are at higher risk of hypoglycemia should definitely check they should own a glucometer, they should check from time to time, and then they should be able to check when they have certain symptoms that are.
There should be a way of giving feedback.
Yes.
Somebody that can call that, okay, this is my blood sugar, should I continue?
Absolutely, should I stop? Absolutely. And I remember a patient that came in with severe hypoglycemia. The guy has been checking his sugar, it's funny, but all over the book, they were actually mild hypoglycemia, 3.6, 3.4. The patient could not interpret it, so was just still checking, recording, continue using the medication until they came in severe hypoglycemia. So that's actually not good enough.
Well, let's take our last.
I know there's still one more poll.
Okay, let's take the third poll to see how we intensify our treatments after starting.
Okay, so let's launch this.
We have a minute so that we can quickly get to the end and address our questions. So we have about 40 seconds more. How do you intensify your treatment in these patients with type 2 DM diagnosed 7 years ago, has been on metformin 1 gram BD, fasting sugar results usually between 7 to 9 millimole per liter. The weight has come down from 40 to 37 kilogram, the BMI, and adherence has been good, there's good concordance, but glycated hemoglobin is 8.4%. Fasting today is 146, that is, if we divide by 18, that is like, what is that now? Because we put 7 to 9 millimole.
That would be around 8, so to say.
Okay, so around 8. So let's make our choice. The treatment intensification over the last 1 year has been adequate. Physical and diet activity should be optimized. You should not change medication. You should add glibenclamide to the metformin. You should add vidagliptin to the treatment. You should repeat the glycated hemoglobin in 6 months before you alter or you make any adjustments. So 10 seconds to go. So I think we can.
Okay, so we can end the poll. So most people chose adding a sulfonylurea.
Are they right?
Well, it depends on where you're practicing, so to say. A deep flow inhibitor will be preferable because of the weights. It has better effect on weight in this patient that is so overweight or obese. Okay, so vidagliptin will be preferred here, even though sulfonylurea will be acceptable if cost is a constraint or where if it's not available, it's not available. Okay, so I think we'll say that the two answers are correct, even though the vidagliptin will be the preferred answer here.
And we talked about the glycated hemoglobin to check every 3 months.
Every 3 months.
6 months.
Okay, so 6 months will have been okay if treatment was not changed or the A1C was good. But in someone with A1C of 8.4% now, it would be inappropriate to actually wait any further before adjusting the treatment.
Then the diet and physical activity, that's like a base, like a foundation, which must be reinforced
every time. But that should not stop us from adjusting the treatment. Because many patients, actually, when you want to intensify their treatment, they will tell you that doctor, let me go and work on my diet. And that's like what the patient has been saying over the last X years, or the last 7 years, that the A1C and the fasting has remained. The fasting between 7 and 9 is very poor, actually.
I took a lot of weight last week.
Exactly. So there will be a reason, and then, okay, and of course, treatment intervention over the last year was not adequate by any means. So, okay, you shouldn't be managing a patient, and the fasting has been between 7 and 9, and then we're just doing the same old thing that we've been doing. So, treatment intervention is one of the big areas where we need to improve as clinicians managing diabetes. So I think, Dr. Alison, we need to be a bit faster now.
Yes, sir.
I'm not sure, should we take some Q&As now before we finish the presentation? Is it feasible? I hope we won't distract us.
If we have
let's take like 5 questions before we go. Let's take 5. Okay, so I can't see this now. Okay, so someone was saying likely A1C has higher specificity for diabetes compared to random because it looks at the last 3 months. Well, I won't say specificity, it's just more durable. Actually, for the glucose at that time, the glucose is more specific for the glucose at that time. But in diagnosis for diabetes mellitus, I would say the A1C likely has more sensitivity, actually. It has more sensitivity than the glucose in time, than the fasting in time, okay?
So let's take these two together. Does hyperglycemia affect erythrocyte turnover? Then is a regular glucometer better for screening or a lab test?
Should be done. Okay, so let's see. So the hyperglycemia, yes, it affects erythrocyte turnover in many ways. There's a lot of relationship between hyperglycemia and anemia, and hyperglycemia can even slightly increase erythrocyte turnover itself. But I think those effects are mild and they're not likely of any clinical significance in itself. That's the effect of hyperglycemia and erythrocyte turnover. So yes, there are a lot of ways in which diabetes and hyperglycemia can contribute to anemia. And that's a whole textbook on its own.
So glucometer and checking in the lab. Okay,
so in a laboratory, actually, in a lab test, the test that should be done for glucose, it should not be a glucometer test. Ideally, it should not be a glucometer test. And all laboratories should have the chemical analysis way of doing the glucose itself, and that's how it should be done in the laboratory. Unfortunately, I know in many labs for cost and some other reasons, it's still a glucometer that is used, but that's not the ideal. So the full method using the exokinase or the glucokinase method should be followed in the laboratory for you to get reliable reasons. Glucometers themselves, they're not so reliable, and that's one of the causes of the discrepancies with the A1C as well. So glucometers are not that reliable, particularly in determining the diagnosis of diabetes, particularly in the borderline zones as well. And that's why the A1C, again, comes out to trump fasting sugars in many circumstances.
So the conclusion is, as you're using your glucometer, by the time you come to the hospital, the lab test should be done.
Should be done with a chemical analytic method. Okay, so the third question here is, what's the role of fruits in the management of diabetes? So that's a slightly tricky one as well. We encourage patients with diabetes to take their fruits. We know that fruits are sugary, and because many fruits are sugary, we should encourage them to take it in controlled portions. Okay, so someone with diabetes should not say, I want to take 5 apples, I want to take a whole watermelon. Your sugar is going to spike up. So we should take it in a controlled portion in the context of the overall caloric intake they're taking. We should know that the fruit should be taken wholesomely, not the juice, because a lot of the soluble fibers in the fruits help to mitigate the effect on the glucose, right? And of course, the portion should be controlled. So that's it. So they should take it. Yes, it can raise the sugar a little bit, but if the portion is controlled, the sugar should not go too high. But we should not sacrifice fruits because they contain sugar. Otherwise, we'll miss out on the micronutrients and the multivitamins that the fruits also contain, and antioxidants as well.
Shed more light on the A1C
testing and modalities and the kits that are preferred. Well, what I'll say to this is that there are many assays, and I can't really talk about specific kits here. Many assays, each assay, the assay we use should be understood one, and we should make sure that it is certified by the certification agency. I can't remember the name now. I have to check that name now. The NGSCP2. There is an agency that certifies A1C assays for diabetes care. So that's the NGSP certification. So we should make sure it is certified by that. And then we should look at the pros and cons of whichever assay is being used in our hospital so that we understand it. And then if you have so kind of results. We know the kind of questions we'll ask the patients. But I cannot say that one particular, depends on what is used in your workplace as well, but it's important, it has to have that certification. If it does not have that certification, then it cannot be used to diagnose. It can be used to monitor perhaps, but it cannot be used to diagnose. I think I'll just take this one before we continue.
I think maybe we should leave this one for the dietitian to answer.
Which one is that? Let me see now.
He said when we ask the patient to take
low carb
diet, what do we mean?
Okay.
Is it possible to make a list of our local food with their corresponding glycemic index?
So yeah, when we say low carb diet, it just means that the amount of carbohydrates in that meal has to be low, reduced or controlled. So for example, in a meal, if you're taking a meal, let's say someone is trying to take about 2,400 kilocalories a day, and a person is taking, let's say, 2 main meals of 1,000 kilocalories each, maybe the 400 will be for snacks. In that 1,000 calorie meal, we want the carbohydrates not to be more than maybe 40% of the entire meal. Okay, that's one. And of course, in practice, it translates to having the amount of carbs on our plates to be reduced. So instead of taking 4 slices of yam, why not make it 2 and take some vegetables with it? Take a boiled egg or take boiled egg or a piece of chicken or a piece of fish with it to make up for the other things you need, and a lot of vegetables to make you feel full. So that's a low carbohydrate diet. That is a diet in which you intentionally reduce the portion of the meal that is carbohydrate. Now, many people can take that same yam meal, take maybe 3 slices of yam and then stew without any vegetable, without any other protein and any other thing. No, that's almost 100% carbs in that meal. Okay, so that's basically it. Now, meals with their glycemic index, we can find it on the internet. There's very little use you can use with the glycemic index figure itself. It can help you rank carbohydrates compared to each other, but a lot of things determine which carbohydrates our patients prefer. Usually, I try to compare the swallows. There's someone I'm trying to get to be fit for a hip surgery replacement now. I've discussed and discussed. The wife has told me over and over again that his curry must take for lunch, and we have to be giving a prandial dose of insulin before that lunch. Now, the amount of the gari it takes for lunch is just about the size of this lunch, so you really reduce it. So portion control is critical. A lot of factors will influence what your patient will end up taking. Okay, but the glycemic index itself, that's in terms of a figure, there's very little use it will give you as a clinician. Okay,
we should take the others
later, Abi. Okay,
so that we can finish. So let's quickly talk about.
Okay, so basically, talking about the glycemic targets, we've mentioned a lot of things that we use to determine whether we should give a patient a strict or a less strict glycemic target. Generally speaking, we want A1C to be less than 7. For some patients, you want it to be less than 6.5. For some patients, you can tolerate a little bit if it's higher than 7, sometimes even up to 8. Okay, so in patients who is recently diagnosed, first of all, and we try to, that's not on this chart much, no. Okay, so someone that is recently diagnosed, you want to aim for a better control. Why? Particularly in younger people, because of what we call glycemic memory. How you control diabetes earlier in the course of the disease has a long payoff late along the line. So almost like a compound interest accounting in which the amount you put down.
If you control early, it's better for the patient. It's better off. Let me just be reducing gradually.
Exactly. It's better when you control early, so that at least the damage there's a cumulative benefit of that early control, so to say. So that's one. So okay, so is there actually disease duration? So people that are newly diagnosed, you want to aim for a better control compared to someone that's had long time. So someone that's had diabetes for 40 years. Getting it controlled tight is not probably going to change much, because whatever will have happened to the kidney and the nerves and the blood vessels probably would have happened already. Okay, and of course, in people who have high risk of hypoglycemia and other adverse drug events. So there's a man that we have on the ward now, Mr. A, you know him. Okay, so over time when I've been managing him, because he has been blinded by diabetes, he has hypoglycemia, he has a lot of GI issues. Our target for him was about 8. Once we're getting A1C of 8, we're fine. We're not pushing so much further. Okay. In people who have a short life expectancy, you try to aim for a relaxed glycemic control. You're not trying to make the person live for 50 years or 30 years longer. And people who are young and have likely a long life expectancy, you want to be stricter with the glycemic targets. Of course, comorbidities can make it easier. Sorry, it can make it more difficult to manage. Okay, like a man I mentioned has a lot of GI issues, cannot eat this, cannot eat that, as I've also surgery before. You may need to relax your glycemic control. If people who have established vascular complications, if it's severe already, in which atherosclerosis is established, there's already peripheral arterial disease, the coronary arteries are already clogged. There's very little you're going to be able to achieve by making the A1C target 6.5. So it's better you probably relax it. And then some patients are motivated. They actually want the glucose to be as near as normal as possible.
So highly motivated
Patients, you want it to be well controlled, exactly. And of course, you need, for you to aim for a very tight control, you need resources and a good support system.
Yes.
There has to be access to an endocrinologist, diabetes nurse that they can call, they can absolutely, all those kind of things are important.
So we have to be a bit fast. So let's
absolutely.
intensification.
Okay, so I think we've talked about this. It's important to intensify. I need to emphasize that it's important to intensify.
Don't just wait.
Don't just wait and patient keeps coming and then the sugars keep being bad and then you continue patient on the same old treatments that is not working. Okay, so we need to intensify. I think that's the important thing on this slide. And of course, within 3 months, you want to get to targets, no more than 6 months. If you're not at targets within 6 months, you need to change what you're doing. So that's
send the patients to a specialist
for inputs and advice on what to adjust. Okay, so in choosing the additional agent, I think we've talked about some of this a bit. We talked about the avoidance of hypoglycemia. Okay, we know that the DPP-4 inhibitors and SGLT2 inhibitors are low risk for hypoglycemia. Also the GLP-1 agonists, and everyone on this first line, they don't cause weight gain. We know that GLP-1 agonists and the SGLT2 inhibitors are more likely to help the person lose weight actually. In people who have reduced GFR or albuminuria, you should prefer the DPP-4 inhibitors. You can also use the insulin as well. Okay, but particularly DPP-4 inhibitors, particularly linagliptin, has been well studied in people who have reduced GFR. Now, people who have clinical cardiovascular disease or cardiovascular risk factors, SGLT2 inhibitors and the GLP-1 agonists have been shown to improve outcomes, so to say. So both of them, either stroke, talking of heart attack, or even heart failure, they have been shown to give us benefits in that regard. And people that are planning pregnancy, it's important for them to be on insulin. Yes, you can use metformin as well at some point, okay, but they cannot use this other agent if they're actively planning pregnancy. In people who have a high excess of dysglycemia, you need agents that are more potent, particularly maybe sulfonylureas or SGLT2 inhibitors rather than the DPP-4 inhibitors that have a more modest effect on glycemia. Of course, we have to be mindful of costs, and we know that in Cardiocare, for example, heart failure patients without diabetes will benefit for SGLT2 inhibitors, and then of course the ones with diabetes is a no-brainer to put them on SGLT2.
About planning pregnancy,
yes,
I've heard about metformin.
Yeah, so we can use metformin in people that are planning pregnancy. Metformin actually is being used more and more in pregnancy. I think it's actually safe in pregnancy, but of course the consensus is not yet very full. What is recommended by most bodies now is that people that are on metformin before pregnancy, you can safely continue the metformin. The NICE are more liberal towards this. NICE UK is more liberal towards this. ADA in US is still a bit more skeptical about using diabetes in pregnancy, using metformin in pregnancy for diabetes.
So how do we follow them up and assess cardiovascular risk and other complications?
Absolutely. So again, we've talked about the targets, and then we should reassess and make sure that we meet the targets in 3 and 6 months' time. We should assess that we're meeting the targets. It's also important to ask patients about hypoglycemia during the clinic visits. The high exam should be done at least alternate years. Usually we used to recommend annually, but a lot of studies have shown that you can actually do it alternate years in people in which the findings are normal. Now, in people with abnormal findings, the frequency should be determined by the severity of the abnormal findings that were found there. Now, comprehensive food evaluation should be done at least quarterly. There's a lot of reasons for this. Now, it's almost okay to do it annually, even though it's not okay. But apart from you finding and advising on the foods when you examine the food of the patient, actually, I found that examining the food of the patients myself also draws the patient's attention to assessing their own food and being aware that food problems do occur in diabetes and that they should be mindful of their food as well. And of course, we should make sure that the patients do their annual tests, including their creatinine, lipid profile, and urine albumin. Those should be done annually. So talking about cardiovascular disease, Dr. Olalekan.
Like I said at the beginning, that the burden of cardiovascular disease is increasing.
Absolutely.
And hypertension and diabetes are the main driver. So it increases the risk of developing stroke, myocardial infarction, which we are seeing every day.
Absolutely.
That old belief that there's no myocardial infarction, ischemic heart disease in black in Nigeria is a big,
long discarded.
big fault. So in patients with diabetes, you need to assess their risk. So using different calculator, doing the basic. So as you're telling them to get their glucometer, you should also encourage them to also get something to measure their blood pressure. You have to look after their cholesterol, and that's why I said annual cholesterol check
is important.
Kidney function tests, follow up to make sure that we identify.
Absolutely. And because we know that the risk of stroke and MI and heart failure is very high, and that we have said that diabetes is a cardiovascular disease equivalent, coronary artery disease equivalent.
And even with the peculiarity of this presentation, where the patient will not have any pain.
Absolutely, because they can have the so-called silent MI. So we need to be aggressive with them. And the cardiovascular risk factors we need to pay attention includes hypertension, cholesterol, turbos, weight, and of course smoking. I've realized in my practice in Abuja that smoking is actually much more common here than in the Southwest for many reasons. So we need to ask. There are a lot of patients I almost did not ask about smoking, and then I asked them and they just said that, Doctor, I smoke. I'm like, there's a particular man I've been managing. I've had diabetes for more than 10 years. He told me he still smokes more than 10 packs a day. I didn't know this. And if we don't address something like that, invariably, it's going to make our patients worse off for it actually. Okay, so we mentioned a lot of these things that we need to put an eye on, and I think I'll be brief with this. Hypertension is critical to recognize and manage hypertension. A lot of bodies have recommended that we should chase a systolic target of a BP target of less than 130 over 180. We should try not to allow patients to excuse their blood pressure. So many times they tell you that it's because of this, it's because of that. Please let's take it with a pinch of salt. When there are doubts about it, we can recommend them to do a 24-hour blood pressure profile, which we offer here in Cardiocare. The way they devise, I'll check the BP over 24 hours, and they bring it back the next day, and then you analyze blood pressure. So we should have a very low threshold for treating hypertension in diabetes.
Yes, we're actually telling ourselves that the guideline says presence of diabetes with any stage of hypertension requires treatment.
Absolutely. I totally agree with that. And of course, we give preference to using a ACE inhibitor or an ARB in people with diabetes. Any of the ACE inhibitors or ARB you use is probably fine. And of course, if that's not getting a patient to go, we should consider adding a calcium channel blockers or one of the other agents. It's important that we treat the blood pressure to go. Either the systolic or diastolic, even if it's just one that's elevated, we should treat that to target. And next, we come to the lipid profile. We should assess the lipid profile in people with diabetes. In Cardiocare, we assess that annually in people with diabetes, whether or not you're on treatment. In people in which it is grossly abnormal or they're on treatment, or we just made a change to their treatment, you should reassess it in 3 months' time to see that whatever you're doing is working. And we see a lot of cholesterol derangements. And of course, if there's cholesterol abnormalities, particularly in the total cholesterol or the LDL cholesterol, we should place a person on a statin. In people with triglyceride issues, which I have quite a bit of, if triglyceride is high, in this guideline, they say if it's greater than 500, where we know there's a risk of pancreatitis and other issues, and also makes the LDL cholesterol reading unreliable or undetectable, we may need to treat those with the fibrates. But the statin therapy is the key part. And some people actually argue that most people with diabetes should be on a statin, which I agree with. I'm not sure I'll say that that's the truth in my practice, again, we should assess the lipid profile, and once we have derangements in the in the total cholesterol, and particularly the LDL cholesterol, we should place them on a statin. Now, again, I realize that many of us prescribe statins on a short-term basis, and I do so sometimes.
Ridiculously low dose.
At some ridiculously low dose. So most people that require a statin, that genuinely require a statin, require it long-term actually, because we know that the benefits or the cholesterol reduction we achieve with it reverses after you stop the medication.
And the guideline actually tells us that once you can establish any atherosclerotic cardiovascular disease, stroke,
peripheral arterial disease, coronary artery disease,
use of statin is
lifelong. It's lifelong.
Even in the presence of normal, similarly normal cholesterol level.
And we do know that even at whatever level your cholesterol is, you give some vascular protection by lowering it further, irrespective of the baseline LDL cholesterol. So I encourage us to try to use the statins, either atorvastatin 20 milligram, rosuvastatin 10 milligram, should probably be the minimum you prescribe for someone with diabetes that merits a statin. as long as they are tolerating it. So someone 10 milligram of atorvastatin is small, 5 of rosuvastatin is small, except if the person is not tolerating it. Of course, sometimes we use those low levels in people that are much older and we're aware of certain medication. It's also important to calculate the cardiovascular risk using the Ascvd risk estimators. Those can give us guidance in managing some patients that are in certain gray areas, and can also give us guidance on the potential benefits of aspirin in certain groups of people. We know that the role of aspirin in primary prevention is limited.
Yes.
It's well established for secondary prevention, but some people will still benefit from aspirin for primary prevention, which their 10-year Ascvd risk can guide us on that. Once it's greater than 10%, then we may be able to justify the aspirin if their bleeding risk is not high.
So let's talk about things to check when they come to the clinic.
Absolutely. So the things to check I think we've talked about this a bit. So when patients come to the clinic, we should ask them questions about their adherence, we should look at their glucose trends, we should look at their risk, we should ask about their recent A1C. We should ask about how much they're doing in terms of diet and exercise, how many days a week they exercise, what their diet has been like recently, how often they veer off eating a healthy diet. We should ask them a little bit about their knowledge on diabetes, whether they understand diabetes, that is a lifelong disease, the complications that are possible, and we should use the opportunity to educate them further. We should ask them symptoms of chronic complications, including peripheral neuropathy, eye disease, erectile dysfunction in males, etc. We should examine their foods, and then we should make sure they do their food and their annual tests, which we've talked about earlier. We should also make sure that they've had a high check in the last 2 years. We should reevaluate their medications in context of all these things we've done above and optimize their medications. And we should make sure that they get a multidisciplinary interaction. They should see the dietitian, they should see the,
dietitian, the people with food problems.
They should see the educators, the podiatrists as well. So they should have that kind of multidisciplinary interaction, and that will make their clinic visits to be very viable. Before I leave that part, I think I'll just mention that we need to more aggressively assess for the vascular complications as well. Okay, we need to make sure that they don't have, whether ask them about angina. Many of these things are there, but if you don't ask, you don't know. So we've seen that a lot of patients will just come out with an heart attack out of the blues. Many times it can be totally out of the blues, but many times they've actually been having some angina or angina equivalents all along the line. Some patients have had TIAs before and they did not tell anybody because the thing just resolved on its own. So we need to ask, we need to examine the peripheral pulses. And if you said that by the time you have peripheral arterial disease by palpation, there's likely some coronary artery disease as well. And of course, we can do Doppler ultrasound as indicated, etc.
We assess for complications. Which we don't usually do.
We often don't do. So, but I think if we do that better, then we can reduce the burden of macrovascular complications among our patients with diabetes. I think we are very out of time, Dr. Olalekan.
So, quickly, I just want us to talk about this technology.
Absolutely. So, a lot of technologies that are in use for diabetes now that is not yet widespread or common at all in Nigeria. One of them is continuous glucose monitors. In people who are intensively treated with diabetes, who are likely on multiple daily injections, down a basal bolus regimen, or even a twice daily insulin regimen, they have to check their sugars several times a day. Many check up to 4 times or 6 times a day. And many of them can actually benefit from what we call a continuous glucose monitor. A continuous glucose monitor is a small device that is attached to the skin, like seen on the screen. And then it has a little needle that goes into the subcutaneous space and is exposed to the interstitial fluid, and then it continuously checks the sugar level actually. So the sensor is attached to the skin, and then this transmitter or the monitor is placed on it. And in this patient, the glucose readings can be seen in real time on the screen, either on their mobile phone or on some other the well. And the good thing about it is that it can give a lot of feedback for the patient and for the doctors. So there are 2 ways that this is done. Someone can actually be wearing this as part of their diabetes treatment, and then some people can just have it done as a test in the hospital. So you just come to the hospital, they feed this on you for 2 weeks or 1 week, and you go on with it, you go do your normal stuff, use your normal medications, and then you come back.
Event monitor.
Absolutely. And then we see the trends that the glucose goes. So when you eat this kind of food, it does this. So at night, the sugar dips around 2 a.m. with this kind of insulin regimen you're on. And it can give us a lot of information useful to treat the patient. Also, in people who wear it as part of their treatment, they can actually get alarms when their sugar is falling low, because glucose does not just go to 38 milligrams per day, for example. It must have come from 70 to 65 to 60. So once the trajectory is down like that, it can actually warn the patient that, okay, your sugar is getting low, okay, and then they can do something. They can eat a snack. For example, imagine someone's sugar starts getting low while he's in the middle of playing football. If he knows that the stuff is in this range, okay, so it gives a lot of information, and it's actually more and more part of management of diabetes, particularly type 1 or other insulin-treated patients. So by the time we see the stuff, we can see a lot of features on the time the person spends in the therapeutic range, how frequently the sugar is high, how frequently is very high, how frequently is low, how frequently is very low, and then those information can be used to help.
Is it available in the country?
It's not really been officially launched in the country, but we have quite a bit of patients that are on it. Most of them actually got it started on from outside the country, but it's actually every user involved, so it takes a lot of motivated. It takes a patient that is highly motivated, usually youngish and tech savvy to use it. But most patients that use it are actually very happy that they have it.
I don't think we should end this presentation without talking about insulin use.
Yeah.
So maybe you quickly talk about.
Okay, so I'll just talk about the infusion pump briefly. So infusion pump is very useful in patients with type 1 diabetes or other patients that require insulin treatment, especially in patients that it's difficult to get a control and you are flexing between very high and very low readings. Okay, so those kind of patients can benefit from an infusion pump, and it's best used in context of a continuous glucose monitor. In fact, in people who have the glucose monitor and infusion pump, the pump take readings from the sensor and can actually automatically control high, can also automatically adjust low insulin by stopping the delivery of the basal component of the insulin secretion. So it's something that is very, very helpful, particularly in patients that have type 1 diabetes and are struggling to attain or maintain glycemic control or having too much hypoglycemic episodes while using their typical insulin regimen. It's also more particularly useful for patients that are very active, particularly athletes, in which by the time you're running around, you're playing your rugby, and then you see that your sugar starts going low because you didn't know it was like this before. So that information can be helpful. So basically, there are many insulin infusion pump systems, and I'm sure that within the next few years, we'll have a little more of them in Nigeria as well. We have a few patients with them, like I said, but most of them got started on it outside the country, and we are just continuing, helping them to continue the use. So the insulin use, which is the final segment of this presentation.
So when do we use insulin?
Let's quickly take the last poll for the day. Let's take the last poll for the day. Sorry that we've taken quite a bit of time. So this is the last phase. I think the question will be.
Let's do this in 45 seconds. Because,
please, let's participate very well.
We're out of time.
Absolutely, we're out of time. We need to finish.
So 60-year-old with type 2 diabetes diagnosed about 30 years ago. A1C a year ago was 7.8%. She's taking Gavosmet 150, glimepiride 6 milligram. I've been fasting 152, A1C 8.4, BMI is 33 kilogram per meter square. So which one is correct?
A1C 8.4. The last a year ago was 7.8. Was poor as at that time actually. And the mean fasting of 152 is quite high. How should we address this patient? What should we do?
So what do we do?
Let's participate, please.
So we advise her to further reduce her caloric intake and exercise more. Do we change the glimepiride to gliclazide? Are we to start basal insulin and stop the other medication? Start twice daily insulin injection while stopping all other medication? Or we continue to monitor and reassess A1C in 6 months. So So let's see.
Okay, so I think it's time to end the poll. So this is actually a common clinical scenario. A patient that is appearing not to be doing well on maximum dose of oral medication, depends on already on 3 medications at the peak doses. So out of all these answer, the one that will be most appropriate would be D. Commence twice daily insulin injection while stopping the oral medications.
But can't we also try C?
Yeah, C will not be appropriate because we can't use basal insulin alone.
No, that's what I'm saying. That what modification can we do to make C applicable?
Yeah. So if we are using C, then we would probably maintain at least the metformin, perhaps maintain the Galvus as well, or we might stop the glimepiride or reduce it. So, but the 2 options in managing this kind of patients will be to start insulin. If you're starting basal insulin, usually you reduce the sulfonylurea or stop it, and you might continue the metformin plus or minus the vidagliptin. But if you're starting twice daily insulin, you can stop all the medications, but usually it's better to maintain the metformin because maintaining the metformin will reduce how much insulin you are going to require because it improves insulin requirements. So I think I was actually meant to still edit the question, but I didn't get to do that. So, but basically amongst these options, the way they are right now, D will probably be the most appropriate, even though it's good practice to maintain the metformin, except in certain situations, so to say. So, but briefly, let's just quickly run through this. Hopefully, we should finish this part of the presentation in the next 3 minutes, hopefully. So, when do we need to start insulin? When the glycemic targets are not met, despite the maximum dose of the oral agent, just like it was on the last slide. In severe symptomatic hypoglycemia, or patients that have very high A1C, greater than 9, according to the ACE and many other guidelines, when you have greater than 9 A1C, you should probably consider starting insulin, even if it's temporary. When there are contraindications or intolerance of the oral agents, in acute illnesses, sepsis, infections, MI, trauma, we should consider using insulin. Of course, in hyperglycemic crisis, that goes without saying. And then in pregnancy, you should also consider using insulin as well. So, like we said from that page, we can either start insulin as basal, and typically we continue the metformin plus some of the other oral agents. We can also start premix insulin, like the 70-30, 75-25, in which we start in this typical way, but usually we stop the secretagogues. Why? Because if you use a secretagogue, like the sulfonylureas with insulin, the risk of hypoglycemia is extremely high and it's going to be erratic because before you start the insulin ab initio is because there's likely beta cell failure. When you start the insulin, sometimes the beta cell can recover a bit, and if they start recovering, your secretagogues may work briefly and can start having hypo. So, of course, it's important that when we start insulin, we titrate upwards until control is attained. There's no maximum dose of insulin. There's a starting dose, and you titrate until you get adequate response. Again, overall, it's important to monitor, to educate the patients about using insulin, about the risk of hypoglycemia, and then we should also continue to reassess the continued needs. There's some patients that started on insulin just for a plan to be temporary, but just disappear and they just continue using insulin, whereas I should have refined the dose along the line. So,
is it appropriate to allow patients to do self-adjustments of their insulin?
Yes, it's appropriate to actually teach them and encourage them to be able to, but it needs to be done the right way. That's important. So I've had some patients that do it the wrong way. For example, adjusting the amount of glargine insulin, which is a basal insulin, with the amount of milk you take. No, that's not correct. Okay, so you should teach them the kind of right thing to do. So usually it's good to give them an algorithm of which they can actually self-titrate the basal insulin until the sugar gets to targets, and then they can maintain the dose that controls the sugar. So basically, we have a lot of barriers to insulin use.
I know a lot of doctors. Some doctors are afraid. Once you talk to insulin, no.
Yeah, right.
Some doctors are afraid.
In fact, there's a patient I saw recently that was started on insulin by a cardiologist somewhere properly, and then they prescribed basal insulin at night, Lantus insulin actually, and then they said they went to a nearby hospital, a chemist or somewhere to have insulin injected. This is insulin at night. How can you use insulin at night? No, they cannot give it. In fact, the reason they came back there was because they thought that doctor prescribed something else. When they got there, I said that there's nothing wrong with using a basal insulin at night. It's actually most commonly used at night, and I had to educate them. So it's good for us to have a good grasp of insulin treatment because the truth is that many patients with diabetes, more than 50% of patients with diabetes will need insulin sometimes along their life course. That's the truth. So, of course, the patient have their fears of needles, of scars, which is not a they should not be worried about, stigmatization. Over the years, doctors have made it sound as though it's because patient failed. That's why they require insulin. It is not true. It is not true. Patients need insulin because insulin deficiency or failure of insulin action is central to the pathogenesis of diabetes. Of course, the cost in administration and of course cost is a real concern actually. Unfortunately, insulin is fairly expensive compared to other modalities of treating diabetes. Of course, there are other valid concerns about weight gain and hypoglycemia, which are things that we can control and we can have a grip on. And of course, we physicians, we need to improve our knowledge of diabetes. We need to create time to follow up this patient because if we start someone on insulin, you actually need more time to manage that patient. That's the truth. It's not a patient that you can just give medication and then go.
I think with the advent of pen,
it makes it
difficult
easy.
in administration.
Absolutely, you're right. You're right. So we should offer our patients pen-based insulin. The era of needle and syringe for administering insulin and then patient is doing eye and looking at that needle is gone. And of course, it's easier to make mistakes with the needle and syringe. It's actually more difficult to make mistakes in the dosing with the pen devices as well. So I think that should end the presentation discussion.
Yes. I think we've had a nice time.
Yeah.
Discussing outpatient management of diabetes. We thank you for staying with us for the last almost 1 hour 45 minutes, and I think let's address the remaining part.
Absolutely. So
that we have.
Okay, so we'll just take all the remaining questions now to read the discussion. Sorry, I didn't get that. Okay, so there's this question now. What's the place of 2-hour postprandial test in the management of diabetes? So the 2 hours postprandial is actually critical in managing diabetes. It's very critical. And we say that by the time the A1C approaches normal, by the time it's getting less than 8, the proportion of the dysglycemia that the 2 hours postprandial contributes to is higher. Okay, so in the more severe hypoglycemic state, is more of the fasting. Of course, we know that the fasting state is through the night. Okay, but the postprandial states start to contribute more by the time it's you're getting to that A1C. So what many guidelines recommend is that you should manage, at least you get the fastings to go initially, and then after start watching the postprandial as well. And of course, the postprandial is the one that gives patients feedback on the meals. Okay, yes. So a patient that normally gets a postprandial of 130, 142, and then he had one food one day that maybe someone touted as a miracle food, and then he got 180 after. Nobody needs to tell that patient that food is a no-go zone for him, or at least he should change the manner in which he eats it. So that's the role of the 2-hour postprandial in the management. Of course, in the diagnosis is more limited because we know that the meal is not standardized. So 2 hours post in the diagnosis is more of a OGTT thing. So 2 hours post a measured and a timed glucose load. If it's after a meal, a patient could have gone to eat garden egg and cucumber for all you can.
And like they said that all of us will eat breakfast, but what we eat differs. So
absolutely. Okay, so someone says that can
children be sent for
investigation? Absolutely. In fact, most of the C-peptide and fasting insulin we do is actually in children.
Yes.
But in children that maybe look like type 1, and then maybe they are obese and some things suggest type 2, especially these days where we have the prevalence of type 2 in children increasing. I have about maybe more than 10 children with type 2 DM here, and they're doing fine on oral and lifestyle changes. Okay.
So is glibenclamide still a drug of choice?
Well, glibenclamide is a good drug. We know that the sulfonylurea, globally, the sulfonylureas are falling lower and lower on the ladder of choice, actually. I personally don't like glibenclamide because of some issues related to cardiac ischemia, which is controversial. And then basically, glimepiride is preferred among the sulfonylureas compared to glibenclamide. But in terms of the second line agents, I think most people will prefer the DP4 inhibitors, even the SGLT inhibitors, before you get to glibenclamide. But of course, we cannot ignore availability, accessibility, particularly the financial components. Okay, but amongst the sulfonylureas, many of us will prefer the glimepiride rather than glibenclamide. The outpatient treatment seems
like we talked more about type 2. Yeah.
Well, you're right. And that's because type 2 actually forms more than 95% of the patients with diabetes. People with other type of diabetes will likely need more to be seen in specialist setting. Maybe sometimes we can have a webinar on type 1 diabetes, but I'm sure it's probably only endocrinologists that will be interested in that. And of course, the GDM, we had a webinar on that. That is still on our YouTube channel that we had earlier in the year.
And
the other types,
maybe inpatient and emergency, that would be another one.
I think we'll do another on that. Actually, we actually considered it for this time, but I think that the outpatient still forms the bulk of most doctors. Absolutely.
And from the feedback we got from people, we got more on the outpatient part.
So I didn't hear you talk about the importance of 2 hours postprandial glucose records.
I think we just did.
Okay, so we just did that now. So thank you for pointing our attention to that. When we ask people to do home self-monitoring, a lot of people do just fasting, which grossly does not show us the picture very well. And the way I describe the multidimensional assessing for patients is like looking at the house just from the front view. You need to see the side view. You can see from top. All of them gives you a good idea of what you're dealing with. And so glucose monitoring at home should include fasting, postprandial, even at bedtime and at different intervals. So we should encourage patients to do that. We said earlier just now that the relevance of the postprandial is more as they approach normoglycemia.
Yes.
Okay. So thank you for pointing that out. So Dr. Nicole, consultant gynecologist, posted this, that health education and advocacy are key. What's our opinion on intermittent fasting and its relationship with hypoglycemia in diabetic patients? Okay, so intermittent fasting is one of the dietary methods for weight loss and for even management of diabetes. So I think it's unacceptable. Like we said earlier, it's important to individualize our patient, and what works for one person, what did not work for one person may work for another. So we should know what works for the patient we're dealing with. I have a lot of patients that does intermittent fasting and it works very well for them. But we should be cognizant of the medication that the patient is taking. Okay, so on certain treatment regimens, for example, someone on twice daily insulin, it may be tricky out to do intermittent fasting, okay? But any patient that is on treatment for diabetes that wants to do any of these dietary regimens should actually discuss with their doctors. So intermittent fasting will be inappropriate for someone with type 1 diabetes as well. It should be inappropriate with someone with gestational diabetes, okay? Of course, the duration of fasting can be discussed and can be suited to the patient's medical profile and the treatment that the person is on as well. So, so thank you very much for that. And of course, we know that patients who are doing intermittent fasting are more likely to have hypoglycemia, especially if they are on certain treatment.
Yes,
we should not forget that insulin, the baseline insulin asks for more than 24 hours. So for sulfonylureas too, a lot of them can ask for more than 24 hours. So the patient took the drug last yesterday and is doing one long fasting today, can still affect that. So, but by the time they've discussed with the doctor, I think we can actually always find what works for the patient and the treatments they are on.
So this is advice there that doctors should take courses in nutrition and physical education to help patients that require lifestyle.
Absolutely, I think that's important. And I think if you work in a center where you have a dietitian, I think it's important for you to have frequent interface with your dietitian. Here in Cardiocare, in our weekly CPD meetings, our dietitian presents sometimes, and we learn from her. So I think if you have that constant interface, it can improve our knowledge. And of course, we can take courses, Coursera's, and things like that that can help us to give the right advice to our patient. Because the truth is that many times the advice we give to our patient is actually maybe not the most optimal thing. Yes. So what's the place of OGTT in the diagnosis of diabetes, taking into consideration of full blood counts and A1C? That's a tricky question. So the A1C, it does not have so much place in the routine diagnosis of type 2 diabetes on an outpatient basis, okay? Of course, it's one of the things that we can do when we have the discordance between the fasting and the A1C. I know one of my colleagues did that recently. So it's one of the things that can be done. It's useful for research purposes, but for routine management, it probably will not make so much of a difference.
And I think in GGM patients.
Of course, in GGM, I know it's the criteria, you need it to diagnose GGM. We need the OGD to diagnose GGM. Okay, but in select patients in which you don't have enough information from doing more than one fasting or the A1C, we can add the OGD to it just to consolidate your knowledge on the patient's glucose tolerance and to give the patient the information. Someone says here that we should make recommendations on commonly available foods with low to moderate glycemic index that is optimal for patients with diabetes. I'm not sure I have that in my head fully, but we know that if sweeter fruits have higher glycemic index, the fruits that have more fibers have less glycemic index. Now, determine the things you call fruits. itself is a tricky one, first of all, because there are fruits and then there are some vegetables that are like fruits, okay? But so technically speaking now, for example, tomato is a fruit. There are a lot of berries that are not so sugary, okay? But the fruits, many fruits have a fairly high glycemic index. So things like pineapple, orange, red apple, so those ones have quite likely have quite very high. Things like pawpaw, banana, watermelon still has quite high. And then I mentioned, which one did I mention again now? Okay, I mentioned tomato earlier, which is technically a fruit, has very low glycemic index. Lightning egg, I technically classify it as a vegetable anyway, but will have a very low. Cucumber is technically likely to be a fruit, even though I classify it as a vegetable based on the glycemic index. I'm not sure what it is actually. Okay, but cucumber is very low glycemic index, obviously. And then so things like guava will have lower glycemic index compared to something that is much sweeter, like pineapple. Which other fruits do we have commonly? The pear, what's that pear that they roast? The soursop, I've not tasted it before, but it's likely high. I know that mango, particularly the Abuja big yellow mangoes, they are high glycemic index. Now the mango that, so basically usually based on the taste, you can actually tell how high the glycemic index will be. But there are many websites where you can actually compare that of many fruits. But I'll tell you to take those information on those websites with a pinch of salt. Yes, because the species of the fruits, how likely allow you to get to all this time. So there are a lot of bananas with fairly low glycemic index.
And you talk also about the portion.
Absolutely, absolutely. So the portion will actually go to the glycemic load now, apart from the index. But a lot of things influence it for fruits actually. But usually we tell patients that the very sweet fruits they should take in extreme moderation. Usually we tell them to take just about a handful. I often use this mouse in my hand. Sometimes I tell them about the size of a tennis ball or a golf ball should be about the size of what they should take. It usually translates to about maybe one orange, one medium-sized orange, one medium-sized apple, 2 small bananas that they can take per meal. If they stay along that line, they're likely not to get it wrong. And for patients that have doubts, I encourage them to check their sugar about 2 hours after to see how high it spikes. Okay, so how much foods patient can tolerate too also depends on the degree of glucose intolerance they have. So for a lot of patients in which the glucose intolerance is mild, the fasting sugar is just mildly impaired, many of them can actually tolerate fruits better. That is, the amount of glucose rise they have after even quite sugary fruits can be more modest, okay? Whereas down the line after several years of diabetes, where the amount of beta cell function is grossly reduced and the ability of the pancreas to produce insulin in response to a glucose load is impaired, they can respond to it very poorly. So
let's take this popular question.
Okay, so what's the role of honey in diabetes management? Well, we can use honey to correct hypoglycemia. Honey has more calories than sugar and should not be a substitute for sugar in someone with diabetes.
Honey has more calories.
Honey has more calories than, in fact, sorry, it has more glucose than sugar. It has more glucose than sugar. So it doesn't, we should not advise our patient with diabetes to substitute sugar with honey or with nectar or with, and so we should not advise that. We should encourage them to stay off sugar. A lot of patients, some patients are unable to do it, especially my patients that have lived out of the country before, and some of them still insist on taking it sometimes. When I insist on taking it, I tell them to try to subtract it from the calories they are taking in. Okay. But even still with that, it's not a good idea, okay? But substituting honey for sugar in someone with diabetes does not have any significant additional benefit actually, okay? But the non-nutritive sweeteners like Sweetex and all the likes, they can be used without adding to calories. Even though a lot of people are reluctant about the uncertainties of the health risk associated with this product, okay? But research that is available up to date has not shown any clear-cut health risk with any of the FDA licensed sweeteners, okay? So most of the common ones on the shelf in the supermarkets are probably fine. So, but honey should be used for correction of hypoglycemia. It has a high glycemic index
and not as a substitute for sugar.
No, it will raise blood sugar, obviously. Okay, so there's a question here. Are there vision affectation following metformin and glycemic treatments? I have a patient who complains of visual disturbances. I place down the medication. Current fasting is 12.4. So yes, it's not the medications, but we know that the refraction changes with the osmotic changes of diabetes. So when hyperglycemia is worsening or when it's getting better, refraction can change. But usually we tell patients that if they wait for about 1 to 2 months, it should stabilize somewhere, okay? It should stabilize somewhere. So that lens refraction changes can happen when glycemia is getting controlled, particularly if it's happening rapidly. But the patient, you should just reassure the patient, and usually within 1 to 2 months, it should stabilize somewhere. It's important for patients to know.
What of even this blood sugar?
Yeah.
Are we sure there's no ophthalmic complication of DM?
Well, it's possible. It's possible, but usually it's, except if there is something that specifically that sounds like retinopathy, either that sounds like vitreous hemorrhage or anything like that. But usually better for them to wait a month or two after glucose stabilization before they see the ophthalmologists. Otherwise, if they get glasses at this time, the glasses usually will be useless in 1 to 2 months. But the glucose stabilizes. But I've seen some patients that, at least I had one recently that because of his work, he's an accountant and he looks at the screen a lot, he still had to go to the ophthalmologist and get a temporary glasses. And I'm happy they told him there that the glasses will likely be useless after 1 to 2 months, okay, because the shape of the lens is actually changing with the osmolarity. It's just because of flux of water in and out of the lens of the eyes. Okay, but this current glycemia, if I'm seeing the fasting at 12.4, is actually still quite bad. And I'll recommend that we still intensify treatment as appropriate. So there's a question here that says that in the rural settings where A1C is not readily available,
We talked about it.
or the patient cannot afford it, even at initial diagnosis, are there any other parameters that can be used when considering
institution or adjustment
of treatment? I'm not sure whether it's insulin the person needs. Okay, but unfortunately, we'll have to stick with the fasting glucose, fasting random 2 hours postprandial. I would say that if we're able to do several of these, we can have a good insight. After all, we're managing diabetes before A1C came into play. So
do we still do? I remember then this urine whatever, and they keep looking at the color. I can't remember the name of that test.
I'm not sure. I've forgotten the name of the test too. But of course, a dipstick can give you some idea. Yeah. But we cannot use a dipstick for at least glucometers are available. So we cannot use to assess glycemic control in any way. The more usefulness of urinalysis, apart from checking for protein, is in some people that have not checked their blood glucose, it can be the urinalysis that actually points you to check this patient's blood glucose. So you did urinalysis for some other reasons, and then you saw 1+ of glucose there, and it can prompt you to actually double check the person's blood glucose.
I think we need to check the start box.
Okay, that's fine. That's fine. So let's just quickly finish this. How do you manage the patient with low HDL? Other parameters are normal. Very good question. I wish we had a lot of time to talk about that. We've talked about lipids several times before. The truth is that low HDL actually carries more cardiovascular risk than high LDL. Okay, but the low HDL is not really amendable to medical interventions. So the low HDL, yes, there are some pharmaceuticals that can raise it, but raising it with those pharmaceuticals has not translated into any cardiovascular benefits based on the existing research. So when someone has low HDL, just look at the person that is slightly higher, at a higher cardiovascular risk. We should try to do things like exercise, weight loss, and other things to control it. We should optimize the person's cardiovascular risk only, including optimizing the LDL. That's about all you can do to it. It's been shown that with exercise, you can actually raise HDL, and that one can translate into some cardiovascular benefits, which we cannot separate from the effect of the exercise. Okay. But all the pharmaceuticals that raise HDL, none of them has really translated into concrete cardiovascular benefits.
I think there's also some debate about maybe some foods or something.
Yeah, so raising it with nuts too possibly can have some cardiovascular benefits. So I agree with that totally, Dr. Olalekan. Okay, but using all this niacin, nicotinamide, and other things, even fibrates, does not show. It can raise HDL numerically, okay, but it doesn't translate to less strokes.
Talk about maybe if you all having some HDL
raising effects. It probably will not have cardiovascular benefits. So can patients take tea, milk, Milo, and honey only? So people with diabetes can take, we know that, okay, let me say press like this. So tea bags that are not sweetened with sugar and are not sweetened with Milo are totally fine for people with diabetes. Milk is also fine, preferably the skimmed or semi-skimmed one, and the ones that are low in sugar. Sugar sweetened beverages, including Ovaltine, Milo, Bournvita, are not recommended for people with diabetes or who have cardiovascular risk or trying to control their weights etc. So thank you for those questions. We really appreciate them. I think we'll just try to see if there's any key questions in the chat box. It's difficult to sift through. Let me see if we can quickly see through this. Olalekan, let's just quickly look through this. Time has already gone. So someone commented that some patients think they can only eat carbohydrates and eat only monotonal. So I think as doctors, we should try to change that narrative.
Yes.
People with diabetes are encouraged to eat the regular healthy diets, and things that are not good for people with diabetes are probably not good for anybody else. The role of EUCR before starting treatment. Well, I won't say before starting, but it should be checked as part of the routine check for people with diabetes. And if we notice, but it's not like you don't necessarily have to delay metformin for that, except if you think that, if you see other things that suggest that there may be advanced kidney disease in this person. Okay, so someone has asked this already elsewhere. So someone has asked this already. In a patient with fasting of 30 millimoles per liter with a diabetic foot ulcer, no symptoms. What's the best choice of treatment? Because the person needs to be, there has to be insulin as part of the treatment. So is it that you're doing basal insulin with oral agents, but preferably premixed insulin alone, actually, in the context of diabetes foot ulcer. You need to be able to get that glycemia control within a very short period so that the wound will be able to start healing better. Is it not better for a patient to see a dietitian who will calculate the calorie intake our staple food contain? So that's fine. It's critical for patients with diabetes to see dietitians, actually. It's critical. Everybody who has diabetes or who is trying to get weight under control or indeed has cardiovascular disease or risk factors should be seen by
where you don't have
dietitians.
It's also good to have some basic
knowledge.
That's one. Be able to educate your
Absolutely, that's one. And then importantly, even when the patient sees the dietitian, you as a doctor, don't forget that there are some things that the patient defers to the doctor. You should be able to corroborate what the dietitian says and keep encouraging the patient on that line, okay? Because you are the one that will see the patient at each clinic visit, and you need to ask what the patient is doing, what problems they have. And someone recommends a book here by Professor Anuma. Absolutely, it's an excellent book. I've read it before. Food and Lifestyle Disease, and they focus on diabetes and hypertension. So the book is available, and I read it, and I think that someone says that it's available at University of Abuja teaching of Guagalada. So I think that's virtually all the questions we have here. So that's good. Dr. Olalekan, thank you again for a wonderful presentation.
And you should thank the audience. We have close to 200 people and almost 130 people are still with us till now. So we really want to appreciate you. Thank you for your patience. Thank you for the audience you have granted us today. So this is Cardiocare again, and this is part of our webinar series.
Absolutely. So we try to hold these webinars every month, and it's part of try to advance healthcare in Nigeria, particularly related to cardiovascular medicine. Cardiocare is a multi-specialty hospital in Abuja, Nigeria. We're in Garki, Abuja, Nigeria. And we focus on cardiovascular medicine, diabetes, hypertension, heart disease. And we have one of the very few cath labs in Nigeria. We're very intense about educating people on cardiovascular disease. Just last week, we had the cardiovascular education program.
Foundation with people, some colleagues coming from
absolutely with Dr. Tayo Ado from the US and his team. And I think we were able to do some pro bono coronary interventions, which a lot of patients benefited from all over Nigeria. Like I said, we have one of the few cath labs in Nigeria, and we do a lot of coronary interventions and even peripheral arterial interventions for patients with peripheral arterial disease.
Which diabetes is
a leading cause of. I would encourage us to avail our clients with the facilities we have here at our disposal. We do a lot of cardiovascular investigations and evaluations, including 24-hour blood pressure profile, which we do routinely,
ECG,
Holter ECG, stress echocardiography to pick cardiovascular risk factors and intervene for patients before things get so bad. I'm very sad about the patient we have currently in ICU who had a heart attack and is currently on inotropes. So before things get that bad, we should be able to pick and let patients avail. And of course, we have patients that are like some people asked during the program, patients that need proper typing of their diabetes. We do C-peptide and fasting insulin and insulin autoantibody assays, and which can actually help us make treatment decisions on time. I remember the young lady we had earlier in the year in which she was in the late 20s, and she was a bit on the big side, maybe BMI around 28-ish. And she came with the diabetes. She came in DKA actually, but the panel of tests, the autoantibodies, GAT1 C-peptide actually confirmed to us that is actually type 1 like we thought. And of course, she's able to toe the right line of treatment on time. So all those things are important, and it would be nice to.
Then I think we should tell our people that our annual cardiovascular symposium
is coming in November. Absolutely. So I'm really looking forward to that. To be a hot one.
I hope we'll be able to gather physically this year.
I think so. It's
Okay,
likely to be hybrid.
It's likely to be hybrid,
both virtual and physical components to it. And I will also want to remind our guests too about the other services that we do offer: neurology, nephrology, dialysis. We have Dr. Bakari. Absolutely. Kidney biopsies.
Central line insertion.
Absolutely. So again, one of the benefits that our partnering doctors benefit from the most, of course, is the fact that when a patient is sent for interventions or evaluation, you get a detailed referral feedback, which makes you just be able to pick up without any itch, as if you're the one that actually evaluated the patient yourself. So if you had a coronary angiography or this, you get a report stating the details of and then the recommendations that we made for the patient. So thank you very much once again. Thank you for being with us this afternoon. Sorry we took much of your time. Dr. Olalekan, next time, please.
Thank you. We'll aim to finish on time, but we know we talked about something that is very extensive.
Absolutely.
A lot of people are interested in listening to the details. So we're very grateful.
Thank you very much
for staying with us, and we'll see you
sometimes next month.
Yes, for the next topic.
Have a wonderful day, everybody.
Enjoy yourself. Keep safe. COVID is still out.
Keep safe. Have a wonderful day. Dr. Olalekan, thank you very much. You're welcome.